Okay, good morning. Welcome to the 33rd lecture of Dr. Hydri Step 1. How is everyone doing? I hope everyone is doing good. Can you guys hear my voice? Okay, perfect. Okay, good morning to you all. Um, so, how was the U World solving section of your day yesterday? How many questions did you guys do? Are you guys doing questions in U World that um, are you guys doing questions in New World which are related to psychiatry or still trying to finish neurology? Okay, so how many questions did you guys do? So 25. Okay, what else? Okay. Are you guys done doing the questions related to neurology? Are you guys done doing the questions related to neurology? Okay. Okay, so we have one, two students over here who did all the questions on neurology. Okay. Some are left. Okay. So the thing is, if we finish first date in the first 3 months, so you guys will be done finishing first date, but your U World, you guys will still need some time to finish the U World. Okay. But the only way that you guys can keep in track with the 3 months process is if you do if you do the questions, which are around 38 to 40 questions every day, or let's say even 32 questions or 33 questions every day. Okay. So 33 or to let's say 35 questions every single day. If you guys can stick to that, then you guys will very likely finish UWorld in 3 months. Okay. And that is necessary if you want to sit for the exam in the next 4 to 5 months, then that is absolutely necessary. That is something which you have to do. Okay. Having said that, do we have any new students over here today? Do we have any new students over here today? Okay, so if we have any new students, we want to welcome you to our lectures. This is a 4-hour lecture on USMLE Step 1. What we do is during the first half an hour to 45 minutes, we do revision and recapitulation of our previous topics. After we are satisfied that we have successfully remembered our previous task, then only and only then we move forward and try to finish the tasks at hand for the day. After that, we end the day by solving UWorld notes, and then we do offline UWorld questions. All of this we try to finish in 4 to 4.5 hours. So that's what it is. So that's all. Okay. So hope you and all the other new students who joined have a great time today. Okay. So buckle up and let's begin. Okay. Is everyone ready to do the is everyone ready to do the revision and recapitulation from yesterday? We will do the neurology assessment very soon. We will do the neurology and psychiatry assessment together. Okay, we will do the neurology and psychiatry assessment together. So that's the thing. Okay, because in offline new world, neurology and psychiatry they're together. Okay, and we will also have to do the high yield uh, high yield neurology CT scans and MRI. So we also have to get done with those. Okay, so do not worry, everything will be done in due time. Okay, just keep on following the lectures and everything will be okay. All right. Having said that, are we ready to do a small revision and recapitulation of yesterday's lecture, please? Okay, perfect. Perfect. Okay. Okay. So, can anyone tell me what are the positive symptoms that we look out for in a psychiatric patient? And I would expect some fast answers, please. Okay. Negative symptoms. How about some of the negative symptoms? Okay, good. How about if we have to diagnose a patient with schizophrenia, what are the five symptoms that we look out for? And I will ask you this one by one. So, what is number one? Number one is delusion. Very good. Number two is hallucination. Then number three, disorganized speech. Then disorganized behavior. Okay. And negative symptoms. Very good. How many of these symptoms have to stay for how long in order to be diagnosed as schizophrenia? Diagnosis would require more than how many? Diagnosis would require at least two or more of these symptoms, or at least one to three symptoms, that is, delusion, hallucinations, and disorganized speech, for a period of at least how long? 6 months. Very good. Very good. Very good. Okay. Now, if I tell you that these symptoms are present in a person that is less than 1 month, what is your diagnosis? Fast answers, please. BPD. Very good. If I tell you the symptoms are between 1 to 6 months, it's on the third month. Schizophreniform. Very good. If I tell you that you have a person who dresses up funny, tries to mix up different types of colors, believes in magic, okay, believes in magic, and okay, very good, schizotypal. If I tell you that you have a person who always stays in their room, plays games, okay, has a steady job, does not want to get married, okay, does not want to have a relationship, very good, schizoid personality. Okay, very good. Okay, next one. Next one is you have a person who has come to you with the belief that he is the president of the United States. Okay, and he has had he also thinks that his wife is out there to kill him. Okay, and these things have been there for the last almost 1 month. Last 1 month. Very good. It's a delusional disorder. Very good. It's a delusional disorder. Okay. If I have to ask you about the mnemonics of manic episode, what are the mnemonics of manic episode? Dig fast. Okay. How many of these symptoms have to stay in manic episode in order to get diagnosed as mania? Three or more of these symptoms for how long? For a period of 1 week. Very good. Okay, for a period of 1 week. If these symptoms are not causing functional impairment, what is this term? What is the term called? Hypomania. Okay. If I tell you that the patient has only mania, what is the diagnosis? Bipolar type 1. If I tell you the patient has hypomania and the patient has depression, but the patient has no manic episodes. Okay. If I tell you the patient has on and off sign symptoms of mania for the last 2 years, and the patient stays symptom free for less than 2 months, cyclothymia. Okay. If I tell you the patient uh, right now, in context, the patient has depression for on and off for the last 2 years, and the patient is symptom free for less than 2 months. What is your diagnosis? Dysthymia. Very good. Okay, dysthymia. Okay, very good, guys. You guys are doing absolutely amazing. Once again, I believe you guys are not looking at the book. You guys are just answering from your knowledge. Okay, very good. If I tell you that you have a patient who has come to you with depression, and the patient um, is eating a lot, sleeping a lot. Okay. The patient gets really happy when you give them a good news, but after that, the patient gets depressed again. Okay. Very good. Atypical depression. If I tell you the patient has depression only in winter, then what is your diagnosis? Okay. Okay. How about one patient? How about this patient who has just gone into who has just had a baby, and now the patient who has just had a baby, and has this patient who has just had a baby. What happened is right now she is having thoughts of killing that baby and killing herself. Okay, she's having thoughts of killing the baby and killing herself, and it's been 2 months postpartum psychosis. Okay, can anyone tell me really quick what are the stages of grief? Stages of grief. What are the different stages of grief? Dabda. Okay, denial, bargaining, anger, then depression and acceptance. Very good. Okay. If I tell you the grief stays for more than 1 year, then if I tell you the grief stays for more than 1 year, complicated grief. Okay. Then if I tell you that the grief stays for more than 1 year, and the preoccupation with the deceased or obsession with the deceased is causing functional impairment. Okay. Very good. Persistent complex bereavement disorder. Very good. Okay. Okay. Um, if I tell you that you have this one student, okay, who could not, who got the news that, let's say there's one student who is giving the step one exam, okay, they come across a question which is so difficult. Now the patient is tachycardic, tachypneic, hyperventilating. Okay, the patient has shortness of breath, chest tightness, feeling of impending doom, feeling of impending death, panic attack. Very good. Okay. Okay. And right now, if I were to tell you that, let's say that this patient, okay, let's say that this patient, what happens to him or her is she waits for the panic attack to happen. Okay, she changes her behavior according to the panic attack. And okay, good, very good. It's panic disorder. Okay, good. Another one is if you have a patient who has a problem talking in public or has a problem with performing public speeches. Okay, social anxiety. Okay. And what if I tell you about this another person who cannot go to shopping, do groceries? Okay, agoraphobia. Very good. Okay, very good. Okay, how did you guys remember so many terms all by yourself? Okay, this is absolutely amazing. I really thought you guys would have some sort of confusions, but from what it sounds like, that you guys are doing absolutely amazing. Um, did you guys try reading the text once again, or is it just from the lecture yesterday? Okay, very good. Okay, good. Okay, good. I'm very glad that you guys pay so much attention during the lectures. So that's that. Okay, good. When you guys read it again, is it easier or is it harder after you read the lectures? Okay, that's very good to know. Okay, that's very good to know. Next one. Next one is if you have a person who has the ability, you are absolutely welcome. If you have a person who feels the need to switch the light on and off 5 to 6 times before leaving the room, what is the diagnosis? Okay, and if you have a person who is not happy with how they look, what is the diagnosis? They keep on changing. Okay, good. Okay, good. Body dysmorphic disorder. And what if I tell you about this another person who pulls out their hair every time they're stressed out? Who pulls their hairs every time they're stressed out? Okay, good. Trichotillomania. Okay, trichotillomania. That is very good. So you guys are okay. So you guys have successfully remembered all the psychiatric terms. Okay, all the psychiatric terms. And having said that, Do we have any confusion before we start our lecture for today? Do we have any confusions before we start our lecture? Okay, good. If we do not have any, okay, can you repeat uh, delusion? Okay, so delusional disorder is characterized by having one, at least one, or more than one types of delusion for a period of more than 1 month. Okay, and the person should have only delusion, no other psychotic sign symptoms such as hallucinations or disorganized speech. So only delusions. That is delusional disorder. Okay, and trichotillomania is basically a person who is stressed out, and when he or she when they get stressed out, they deal with that stress. So they think about that stress, and they sit down, they think about it, they stress about the whole thing, and they start pulling their hairs one by one. Okay, they start pulling their hair one by one, and this results in this will result in a shiny, sharp scalp. Okay, shiny scalp. That's what it does. Okay, having said that, okay, next one. Cyclothymia versus dysthymia. How to differentiate in case scenario. What is cyclothymia? Cyclothymia is your presence of hypomanic or depressive sign symptoms, and each of these will stay together. Okay, the easiest way to diagnose or differentiate cyclothymia or dysthymia is purely depressive. Cyclothymia has hypomania plus depression. So first of all, you have to look out for hypomanic episodes. In order for you to look out for hypomanic episodes, you also have to look out for manic episodes. Okay, so if the patient has manic episodes or hypomanic episodes for 2 years, okay, only when you figure out the manic episodes, you can only realize the hypomanic parts will be the less severe portion of the manic episodes. So that's that. Okay, so only when the patient has hypomanic episodes and depressive episodes for 2 years, and the patient is symptom free for less than 2 months and void of depression, that is known as cyclothymia. Dysthymia, on the other hand, is purely depressive. Okay, that's that. Next question. Delusion, not delusional disorders. Okay. What is delusion? Delusion is basically the false perception of reality. Okay. So, false perception of the reality. In reality, the president of the United States, as of still right now, is Donald J. Trump. Okay. Right now, if you start believing that you are the president of United States of America, then you are delusional because you have a false perception of the reality. In reality, everyone knows who the president is, but if you go and keep on telling people that you are the president, then you have a you are you are delusional. That's that. And then again, delusion can be classified into 5 or 6 types. We have grandiose delusion, persecutory, somatic, mixed, jealousy. Okay, those are the types of delusion. Okay, hope that answered everyone's questions. Okay, is there anything else before we move on? Okay, hopefully not. If we have any more questions, please keep it to yourselves and let me know by the end of today's lecture. Okay, so we don't want to waste any more time. We want to keep on moving forward. If you have any questions, please write it down and mention the questions later when I ask you. Okay, having said that, let's begin. Okay, let's begin with today's lecture. Okay, good. So the first thing that we want to talk about today is trauma and stress related disorders. Okay, the first thing that we want to talk about is trauma and stress related disorders. Okay, first of all, we want to talk about adjustment disorder. Okay, we want to talk about adjustment disorder. That is, this is an emotional or behavioral symptom that occur within the first 3 months of an identifying psychosocial stressor, and this will last for less than 6 months once the stressor has ended. If the symptoms persist for more than 6 months, then it's general anxiety disorder. Okay, so what's happening over here is adjustment disorder. So a lot of people, okay, so how about this? Have you heard of the fact that a lot of people are stronger emotionally, that when something bad happens to them, they can deal with it way more strongly than all the other people? Yes or no? Have you heard of people like that? That some people that they are more stronger emotionally than all of the other people. That when something bad happens to them, they can react to it more strongly. And then we have some other people who are not that strong emotionally. And what happens to them is when something stresses them out in their life, that is, we have a lot of stressing points in our life. Divorce is a stressing point, marriage is a stressing point, death of your family members, they are a stressing point. Getting fired from a job, that's a stressing point. Failing an exam, these are all the stressing points. So what happens is you have these stressing points in your life which stresses you out, and then what happens is at least within 1 to 2 months you should be okay. You should be okay between 1 to 2 months. Okay, but try realizing how you feel after something bad happens to you, and you keep on feeling like this. Okay, and you keep on feeling like this for 3 months straight, and the symptoms, they keep on lasting for 3 months. Okay, so that would feel absolutely horrible, wouldn't it? Yes or no? Would or would it not feel absolutely horrible if you keep on feeling sad after you have lost your job for 3 months straight? Okay, and let's say you keep on feeling like this. Okay, and but the thing is, this feeling of yours stays for more than 3 months, but it goes away in less than 6 months. Okay, so by the end of 6 months, this feeling which you are feeling, that has gone away. But for that period of 3 to 6 months, did you or did you not have adjustment? Did you or did you not have problem adjusting to the change? Yes or no? Yes, you had problems adjusting to the change. Okay, the new change was 3 months ago you had a job. Now, right now, you do not have a job. Okay, so that's a big change for you. Okay, the problem that the thing that it took you so long to realize that this is a new change in your life, and you had a problem adjusting to that new change. This disorder is known as adjustment disorder. So, first of all, the number one thing. So, what do you need in order to get diagnosed as an adjustment disorder patient? First of all, you need a stressor. First of all, okay, let me get my page. How do you get diagnosed with adjustment disorder? First and foremost, you need a stressor, and then that thing will stress you out. Okay, give me 1 second. Okay, okay. In order to get diagnosed with adjustment disorder, number one. So what do you need? What do you need is number one, you need a stressor. Okay, you need a stressing point in your life. Okay, so that could be anything. That could be death. Okay, divorce. Okay, okay, etc. So that could be it. And then after that, okay, you say, okay, after that, you stay sad, okay, for how long? Normally, you can stay sad for 1 to 3 months, okay, that's normal, okay. But if it's more than 3 months, then it's disorder. Adjustment disorder, meaning that you're having a problem adjusting to the problem. But remember, it has to be more than 3 months and less than 6 months. Less than 6 months. Okay. So that this is adjustment disorder. Okay. Can you guys hear my voice? Can you guys hear my voice? Okay, good. Okay, so have you understood adjustment disorder? Okay, easy to understand. Okay, next one. Next one is okay. Have you guys ever heard of people who go to war? Do you guys know, or do you guys have people in your family or friends who has gone to war? Who has gone to war? Yes or no? Okay. So what you would realize is people who have gone to wars, okay, people they have gone who have gone to wars, have they or have they not seen really disturbing views or images? Yes or no? Yes. Okay. So what happens is these things, this witness to death, this witness to injury, rape, and all the other horrible sides of war. You know, war is absolutely ugly. So that's what it is. So so all these other things or views of the wars, what they do to a person is that they experience, okay, they experience these these thoughts and images and views over and over and over again. Okay, so do you guys know the term for this type of stress disorder? What is the term that we use for this type of stress disorder? Very good. The term that we use for this type of stress disorder is known as post-traumatic stress disorder. Okay, the term is post-traumatic stress disorder. Very good. And okay, so how do you diagnose PTSD? Okay, how do you diagnose PTSD? PTSD. How do you diagnose PTSD? First and foremost, in order for PTSD, again, number one, there has to be a stressor. Okay, something has stressed them out. Okay, and with PTSD, you keep on experiencing this stressor over and over again. Okay, you keep on experiencing this stressor over and over again. Okay, and for PTSD, there is one mnemonic. Okay, first of all, these mnemonics can help you diagnose PTSD very easily. Number one, H for hyper arousal. Hyper arousal. Okay, meaning that you're always aroused. Okay, you're always anxious. Okay, it's difficult for you to go to sleep because you're always on an edge. Okay, okay, so this is known as hyper arousal. Next one. Next one is okay, avoidance. Avoidance of stimuli. Okay, avoidance of stimuli. Okay, avoidance of stimuli, meaning that basically what would happen is let's say that let's say that there is something which is really bothering you. Okay, let's say that there is something which is really bothering you regarding your past or regarding a war. Okay, and the thing is, you know that uh, if you re- tap into the reality right now, you are in your house, in your room. Okay, you are not at war. So if you really want, you can really focus on the stimuli of the room and you can really forget about it. You can really try to forget about the stressor. You can actually try to distract yourself. But these patients, they cannot avoid that normal part of their life. So these people, they avoid the stimulus of being normal and they keep on focusing on the stressor. Okay, that's avoidance of the stimuli. Next one is re-experience. Okay, re-experiencing what? Re-experiencing the stressor. They will keep on re-experiencing the stressor. Okay, and the last one is okay. Last one is distress. Last one is distress. Okay, so PTSD is hard. Hard, H for hyperarousal, A for avoidance of stimuli, meaning the normal stimuli, R for re-experiencing the stressor over and over again, and D for distress. Okay, D for distress. And these disturbance, how long should they last in order to get diagnosed with PTSD? They should last for more than 1 month. They should last for more than 1 month. Okay, that's that. That's that. Okay, are we clear about PTSD? Are we clear about PTSD? Yes or no? PTSD, once again, PTSD, H for hyperarousal, A for avoidance of stimuli, R for re-experiencing the trauma, and D for distress. And D for distress. That's that. And if only that stays for 1 month or more, then the patient can be diagnosed as PTSD. Okay. Then the patient can be diagnosed as PTSD. Okay, good. Hyperarousal. Hyperarousal meaning that the patient has a hard time going to bed. Okay, the patient is always aroused. The patient is always anxious, excited. That's what hyperarousal means. Okay, that's what hyperarousal means. Okay, having said that, okay, let's move forward. The next one is okay. So this is PTSD. We have covered almost everything over here. Okay, right now, if I ask you that you have to treat your patients for PTSD, okay, what will you use? That Treatment for PTSD is CBT, meaning cognitive behavioral therapy, SSRIs, and venlafaxine. Okay, SSRIs and venlafaxine. That's for PTSD. For adjustment disorder, CBT is first line. Okay, so cognitive behavioral therapy is first line. You can also use antidepressants and anxiolytics. Okay, antidepressants and anxiolytics. So that's that. The treatments are not that high yield. Okay, the treatments are not that high yield. Another one. Next one is if I tell you that you have a patient. Okay, next one is if I tell you that you have a patient who has a stressor in their life. Okay, and the patient is stressed out. The duration is between 3 days to 1 month. Okay, this duration, the patient is stressed out about something, but the duration right now is between 3 days to 1 month. Okay, 3 days to 1 month. This duration is between 3 days to 1 month. This diagnosis is known as acute stress disorder. Okay, this diagnosis is known as acute stress disorder. Okay, are we clear about this? If we are, then there is a very high yield thing that we have to understand right now. Okay, that is the symptoms by their duration. Okay, symptoms by their duration. Are we clear about all of this? Okay. Okay, right now I would need you guys to pay a lot of attention. Okay, because this is really important. All right, 1 second. Okay, give me 1 second. Okay. Okay, 6 months. What we are going to do right now is we are going to talk about the science, talk about the diagnosis of the psychiatric illness based on the duration of each of the illness. So you can easily diagnose a psychiatric illness based on the duration of the illness. Okay, so first of all, what we did was we do a timeline. This is a timeline. Okay, timeline is from 0 to 2 years, and in between that we have 1 year, 2 years, and 6 months. 1 second, one. Okay, 1 year. Okay, 2 years. 6 months. Okay, this is our timeline. Now we want to diagnose the diseases. Okay, so first of all, before we start diagnosing the psychiatric illness, first of all, we have to diagnose what type of psychiatric disease this patient has. Let's say there are types of, for example, there are mood disorders, then we have psychotic disorders, anxiety disorders. Okay, we also have childhood learning disorders. Okay, so first of all, if I have to talk about psychotic disorders, then how many types of psychotic disorders did we talk about? Do you guys remember that we talked about schizophrenia? We talked about schizophreniform. We talked about brief psychotic disorder. Yes. Okay. So basically, we also talked about schizoaffective disorder and delusional disorder. Okay. So right now I ask you. Okay. So right now, if I ask you, number one, first of all, if it's between 0 to 1 month psychotic disorder. Okay, so the first disorder that we want to talk about is psychotic disorder. Okay, so if it's been 0 to 1 month, okay, 0 to 1 month, what is the diagnosis? Can I get some fast hands, please? BPD. Okay, good. BPD. Okay, if it's between 1 to 6 months, then what is the diagnosis? If it's between 1 to 6 months, what is the diagnosis? Very good. Schizophreniform disorder. If it's more than 6 months, then what is the diagnosis? If it's more than 6 months, fast answers, please. Can I get some fast answers? I really want to finish the table fast. Okay, good. Very good, guys. This is schizophrenia. Okay. This is schizophrenia. Thank you. Okay. Okay, good. Now another one is if I want to talk about mood disorders. Okay, if I want to talk about mood disorders. Okay. mood disorders. And in mood disorders, we have bipolar disease, and then we have major depressive disorders, right? Okay. If I talk to you about major depressive disorders, how long should the depressive sign symptoms stay? Depressive disorders, 2 weeks. Okay, more 2 weeks. Okay. So this is the mark for 2 weeks. Okay, this is for major depressive disorder. Okay. Right now, if I ask you how long should the sign symptoms of bipolar stay, I mean the manic episode stays for bipolar disease, 1 week. Very good. Okay, 1 week. So 2 weeks for major depressive, 1 week for bipolar disease. Okay, good. And if you are upset about death of a person, after how long will it be complicated grief? How long? I said 12 months, but it should be at least 6 months. 6 months. Okay. It should be 6. Okay. 6 months. It's not 12 months, 6 months. Complicated grief. Okay. 6 months. More than 6 months, that is complicated grief. Okay. Good. And what are the two psychiatric disorders which stays for more than 2 years? Very good. The two disorders that stays for more than 2 years are cyclothymia and thymia. Okay, good. Okay, good. Now let's come to our anxiety problems. Okay, anxiety problems. Okay, we talked a lot about different types of anxiety. First and foremost, if you are anxious about something all the time for more than 6 months, well, what is the diagnosis? Always anxious. Generalized anxiety disorder. Very good. If you're always anxious about something, it's more than 6 months, okay, more than 6 months, then your diagnosis is general anxiety disorder, okay, more than 6 months. Right now, right now, if you have an anxiety related to a certain stressing point in your life, for example, divorce or death, and it's between more than 3 months, but less than 6 months, what is the diagnosis? Very good. Okay, the diagnosis is adjustment disorder. Okay, less than 6 months. Okay, diagnosis is adjustment disorder. Okay, next one. Next one is if you are okay. Next one is what is the time period for post-traumatic stress disorder? We just talked about it. How long? Okay, post-traumatic stress disorder is not less than 1 month. You have to be you have to be so traumatic. Okay, the post-traumatic stress disorder is more than 1 month. PTSD is more than 1 month, right? It cannot be less than 1 month. It has to be more than 1 month. Okay. Okay. Good. So we are very close to finishing our durations. Okay. Good. Next one is if I tell you that you have a patient with that you have a patient who what happens is this patient it's a young patient. Okay, he has certain outbursts in the planes. Okay, keeps on shouting and crying throughout the whole flight. What is the diagnosis? What diagnosis? DMD. Okay, DMD. How long should DMD stay in order to get diagnosed as DMD? What is the duration? Okay, DMD duration. DMD should be there for at least more than 1 year. Okay, for more than 1 year. That then it's DMD. Okay. Okay. The same goes for Tourette syndrome. Tourette syndrome should also be for more than 1 year. Okay. Tourette syndrome should also be more than 1 year. Okay. And that's that. Okay. Another one is if I tell you that you have um, patients with specific learning ADHD, okay, and oppositional defiant disorder. Specific learning, ADHD, oppositional defiant disorder, all of these disorders, how long should they stay in order to get diagnosed as these disorders? How long should Okay, good. Okay, these disorders should stay for more than 6 months. So, what are the specific learning disorders, ADHD, and oppositional defiant disorders? And they should stay for more than 6 months. They should stay for more than 6 months. Okay, good. Having said that, we are more or less done for our durations. Okay, now can we do a fast revision and recapitulation? First of all, psychotic symptoms less than 1 month. Fast answers, please. 1 to 6, 1 to 6 months. More than 6 months. More than 6 months. Okay. Now, okay. Next one. Next one is okay. Depressions. Okay. How long should it last in order to get diagnosed as major depressive? 2 weeks. How long should manic episode last? Diagnosed bipolar. 1 week. How long is complicated grief? How long is complicated grief? More than 6 months. Daytime megalothamia. 2 years. Okay. How long would anxiety last in order to get diagnosed as GAD? How long should anxiety last in order to get diagnosed as GAD? More than 6 months. Very good. Okay. If you have anxiety for less than 6 months due to a stressor, what is the diagnosis? Adjustment disorder. Okay. If you have an anxiety due to a stressor for less than 1 month, what is the diagnosis? Less than 1 month. Acute stress disorder. Okay. Good. Next one is if you have mood disruptions for a child for more than 1 year, well, what is the diagnosis? Okay. If the child sticks, then what is the diagnosis? Tics. Tourette syndrome. Okay. Good. Okay. So are you guys confident about the durations of the different types of diseases? Are we completely confident and clear? Because we are done with psychiatric illness more or less. Okay. Now, right now, we'll move on to personality disorder. Okay. First and foremost, let me thank you guys for keeping your attention to the lectures, because what you have just done is you have just perfected the psychiatric illness, and this will help you in answering most of the questions from you world. Absolutely right. Okay. Having said that, do we have any more questions or confusions before we move forward? We have a question from Dr. Hassan. In adjustment disorder, if more than 3 months, then we call it adjustment disorder or not? No, we call it adjustment disorder. If it's more than 3 months, yes. I'm sorry. Adjustment disorder is from 3 to 6 months. Okay. Adjustment disorder is from 3 to 6 months. If it's between 1 to 3 months, it's okay. Okay. If it's between 1 to 3 months, it's okay. Okay. Depending that you have had a stressor in your life. You have had a stressing point in your life. That is adjustment disorder. Okay. What is confusing? What is the part that is confusing you? First and foremost, you need to have a stressor between the first 3 months of your life, and then you stress about this, and then you stress about this for more than 3 months, but less than 6 months. Yes, exactly. Okay, you stress about this for more than 3 months, but less than 6 months. Okay. Okay, so having said that, can we move forward today? Can we move forward with this? Are we done with timeline? Everyone, okay, is everyone confident? Is okay, good. Okay. So there is a timeline over here, okay, which we just tried to make by ourselves, okay. But instead of looking at our timeline, which will be a bit confusing, okay, you guys can look at this timeline over here. And if you guys want to do a quick revision and recapitulation, all you guys have to do is come back and see this timeline, and everything will make sense to you, okay. Okay. Having said that, let's move on to personality disorders. Okay, let's move on to personality disorders. First of all, what do you guys know about personality traits and personality disorders? What is a personality trait? Okay, first and foremost, let me make you understand personality trait. Personality trait is each and every one of us have a different way of seeing things, believing things, and then perceiving things, right? There are things we think about people, and then there are different ways on how we respond to people. And my response is different from your response, and your response is different from another person's response. So this difference in our responses and difference in understanding each other and perceiving things, this is known as personality traits. Okay, so each and every one of us have a different type of personality trait, but none of us, okay, none of us are. So all the students, including myself over here, we are all psychiatrically sound. Are we not? Yes or no? Are we psychiatrically sound? Yes or no? Yes or no? Okay. Yes, we are. Okay. We are psychiatrically sound. Okay. Because although we have different types of personality traits, okay, we do not have a personality disorder. Okay. If we were to have personality disorders, okay, if we were to have personality disorders, okay, then what we would have is we would have disorders of personality in which we would have um, different type of pattern in our behavior, okay, and then we would have different types of abnormal ways of perceiving things. Okay, there's a way that, okay, so how about, let me give you an example. Okay, let me give you a small example. Okay, one example. Okay, what do I mean about perceiving things? Okay, what do I mean about perceiving things? Okay, so first of all, let's say that John, okay, this is John over here. Okay, John is walking down the street. Okay, okay, John is walking down the street. John is okay. John is like us. He has no problem. He is psychiatrically sound. He has no personality disorder, but he has different types of personality traits. Okay. Right now, over here through this direction, okay, through this direction, we have we have Jane. Okay. We have Jane. Okay. And she is okay. And Jane is going this way. Okay, so they're just crossing the street. So John is going this way, and Jane is going that way. Okay, Jane is also psychiatrically sound. So people like John and Jane who do not know each other, who are just passing on the street, okay, maybe there's a possibility. Okay, maybe there's a possibility John will look at Jane. Okay, John will look at Jane, and since John is psychiatrically okay, John will maybe look at her, and then John will keep on moving forward. Okay, because there's nothing more or nothing less that goes on in John's mind in perceiving the reality, despite the fact that all John thinks that Jane is just another person, just another normal person who is walking down the street. Okay, who is walking down the street away from him. So John is okay. Okay, right now, if John had a personality disorder, okay, right now, let's say John has a personality disorder. Okay, right now John is okay, right now John is narcissistic. Okay, John is narcissistic, and for Narcissism, let's say, okay, John really loves himself. Okay, that's a personality disorder. That's a narcissistic disorder, that you think the world of yourself, you're the best in the world. Okay, there's no one else better than you. Okay, you are the prettiest, you are the most beautiful person in the world, you're always right. Okay, so John is psychiatrically not sound. So John has a personality disorder. Now John is walking down the street. Okay, John is walking down the street thinking he's the best man in the world. Okay, right now you have Jane again. Okay, who is going down the street, and Jane is normal. Okay, right now Jane is going down the street this way, and Jane is normal. Jane is psychiatrically okay. Jane is a normal human being who is going to work. John, on the other hand, when John goes by, this John, who is psychiatrically not sound, who has a narcissistic personality disorder, John will look at Jane, and John will think, okay, I am 100% sure that this girl over here is checking me out because I'm the best looking person in the world. Okay. And he might even go and try to talk to her for no reason. There's absolutely no reason why these two strangers will come and talk to each other. And then John would go and try to talk to her. And John would try to tell her how amazing he is. Okay. How he is best at his job. Okay. He is extremely rich, and he lives in a big house. He has an amazing car. Okay, everything in his life is okay. Okay, and these things are all fine, but why would a person need to tell this out to another person for no reason? Okay, so this is John having a personality disorder. Okay, all this story is important because you have questions in your URL in which you have to diagnose a person based on personality disorders or personality traits. Personality traits are normal, personality disorders are abnormal. Are we clear on personality traits and personality disorders? Okay. Are you guys happy that your John and Jane are back from that sad sob story yesterday where Jane was supposed to die? Okay, see, I told you they would not die. Okay, they will keep on coming back. Okay, good. Okay, so having said that, now let's talk about our personality disorders. Okay, having said that, now let's talk about our personality disorders. Okay, so in order for us to talk about personality disorders are divided into three big clusters. Okay, three big clusters. So we're going to talk about each and every cluster one by one. Okay. Okay, first of all, let's talk about cluster A. Okay, personality disorder, cluster A personality. Okay, who are the people who has cluster A personality? Okay, cluster A personality. What first aid does is first aid uses mnemonic, which I kind of find a bit, I don't know, like a tad bit offensive. Okay, so what they do is they say WWW, which is weird, wild, and worried. Okay, I personally think it's a bit offensive to call patients weird. So we will refrain from using the mnemonic from first aid. We will try to understand the problems of the patients. Okay, that's what we would do. So cluster A personality. Cluster A personality, what I would like to use the word is the word odd. Okay, odd meaning, so these people, okay, these people are odd. Okay, they do not have any, first and foremost, always try to remember people with personality disorder, they do not have any psychosis or psychiatric conditions, manic episodes, or depression. They have no problem of these sorts. They just have a problem with their personality. And if they fall into one of these three types of cluster A, then you can diagnose a person as cluster A personality disorders. Okay, these people, they're odd. Okay, they have a difficult time. Okay, in difficulty in forming relationships. Okay, forming difficulty in forming relationships, meaning that they have a problem with forming relationships, being in a relationship with another person. Okay, because that's a huge responsibility one has to take when you are in a relationship with someone else. Okay, you have to have complete trust and loyalty. along with that person. Okay, you have to compromise, you have to understand a lot of things that a normal person can do that a person with personality disorders cannot do. Okay, so odd and difference and difficulty in forming relationships, and difficulty in forming relationships is very important. And first, you will have questions surrounding this problem. Okay, first guy over here. Okay, the first guy with cluster A personality disorder. Okay, his name is Eddie. Okay. Okay. This is Eddie over here. Eddie, what his problem is, he is he is always suspicious of his surroundings. So let's say that when he goes outside, okay, when he goes outside to, let's say, drink a cup of coffee from Starbucks, he is 100% sure that the guy behind the counter has mixed something in his coffee, for which, for which he will get sick later. That's Eddie's problem. Also, Eddie had a girlfriend, okay, and they had a very meaningful relationship. They were having a good time for like for like 1 week or so, and like all normal human being, Eddie's girlfriend, okay, Eddie's girlfriend had some normal male friends. I mean, like females can have male friends outside of their relationship, and that is completely normal. So Eddie, being how he is, okay, he started being jealous of of those friends, and he started accusing his girlfriend about the fact that she might be unloyal with him with those friends, whereas those friends are just normal friends from school. Okay, so that's that, and he firmly believes, and he firmly believes that his girlfriend is cheating on him. Okay, he firmly believes that his girlfriend is cheating on him. Number two. Number three is every time that Eddie gets a gift or a present, okay, every time that Eddie gets a gift or a present from someone, okay, he thinks there's some sort of a poison or something that's over there, that's out there to harm him. Okay, so this is your weird Eddie. Okay, weird and odd Eddie. Okay, so cluster A, odd. Eddie is paranoid. Okay, so have you guys understood Eddie's problem? Have you guys understood Eddie's problem? Okay. So number one is Eddie. Eddie is paranoid. Okay. This is our odd friend Eddie. Okay. Okay. Next one. Next one. Next one is my little cousin. Okay. Next one is my little cousin. Okay. I love him to death. But his problem is whenever we have a family gathering, okay, instead of sitting with us, what this guy would do is he would go up to his room. Okay, what he would go up to his room, and he would keep on playing games on the TV. He would not he would not talk to anyone. Okay, and he is 20 years old. He is 20 years old, but he does not have a meaningful relationship. He has not had a meaningful relationship, meaning that he wanted to be with someone. I mean, meaning that there were people who wanted to be with him. Okay, there were girls from his high school who wanted to go out with him, but he decided that he does not want to go out with anyone because he is happy staying how he is by himself. Okay, and he does not need anyone else, and there's nothing wrong with that. He's not depressed, he's not unhappy, he is just happy being by himself. He's extremely introverted. This cousin of mine, okay, the problem which he has is the problem which we have discussed before, and his personality is schizoid personality. Are we clear about schizoid personality? Okay. Okay, good. Next one. Next one. Okay. Okay, next one is we have this one guy over here. Okay. This guy firmly believes, this guy firmly believes that wearing colored clothes will save him from danger. He thinks that road accidents happen because people cannot see other people. So he always feels the need to wear colored clothes when he is on the street, so that when cars are coming, cars can see him, and cars can avoid him, and he can avoid death. Okay. And he also believes that people should pray to rocks. Okay. He also believes that people should make their prayers to rocks. Okay. And rocks have all the powers in the world because rocks are some of the strongest things in the world, and the rocks are the gods. Okay. There is nothing wrong with him. Okay. He has a normal job, he has a normal life. But his problem with relationship is he wants to have a relationship. Okay. This guy, he is not like my cousin. This guy, he wants to have a relationship. But what happens is whenever he goes in front of a girl or any normal person, whenever that girl, okay, let's say Jane, okay, let's say Jane, when he goes to this girl called Jane, when Jane sees how he is wearing these weird type of clothes and combinations and thinking about how rocks are the this and that, so Jane thinks that, okay, I think it's a possibility that I can find someone better. Okay. There's a possibility that I can find someone better. I do not want to be with a guy like this, more or less, because that's how difficult it is for him to have a meaningful relationship, because this guy wants to have a girlfriend but he can't. Okay. But he can't because he gets rejected each and every time, in most cases. Okay. Until and unless he finds exactly someone like himself. Okay. Which is pretty rare. So despite that, any other normal person would have a difficult time being with these type of people. Okay. And this person over here is schizotypal. Schizotypal. Okay. Are we clear on schizotypal? Are we clear on schizotypal? You know, schizotypal wears weird clothes, has weird beliefs, okay, but has a stable job. He's completely normal. There's no psychotic problem. Wants to have a relationship but can't because he gets rejected by other people. Okay. So right now, if I have to talk about the three personality disorders in cluster A, what are the three personality disorders? Who was the number one? Or what was the number one? Number two? What was number two? Schizoid. Okay. Number three? Number three? Schizotype. Okay. These are the people with cluster A personality. Okay. These are the people with cluster A personality. Okay. Now, next one, which we want to go to is cluster B personality. Okay, next one is cluster B personality. Okay, cluster B, cluster B personality. Number one. Okay, number one is this guy. Okay, this guy is not the best guy in the world. Okay, this guy is not the best guy in the world. Why is he not the best guy in the world? First of all, this guy over here is above 18, so he's an adult. Okay, so he's not a young child who can get away with anything. He's an adult. And the thing is, he loves committing crime. Okay, he loves committing crime, carries a gun, okay, threatens other people, harms animals, okay, breaks down things, okay, and um, behaves really, really bad with people of the opposite sex, okay. And another one is he is extremely impulsive. If he thinks something is right in his head, then that's right. This guy over here who does not accept the social norms, okay, the social norms or social etiquette, this guy is antisocial. Antisocial. Okay, and most criminals are antisocial. Antisocial. So they have an antisocial personality disorder. Okay. antisocial personality disorder. If I ask you that you have a same problem in the child less than 18 years of age, what is your diagnosis? Conduct disorder. Very good. Okay. Okay. Next one. Next one is this women over here. Okay. This next one is this woman over here. Okay. So okay, this woman, her name is not Jane. Okay. Her name is Jean. Okay. What is her problem? So she has a problem in which she feels the need to always do drugs. Okay. She feels the need to always do drugs. Okay. Okay. Then she always feels the need to get she always feels the need to get sexually involved with multiple men. Okay. Then she, okay, then she feels guilty. She comes back home. She cuts herself. Okay. She cuts herself. She wants to commit suicide for no reason. There's nothing wrong in her life. Everything in her life is absolutely okay. She has an amazing family. Everyone in her family supports her. Okay. She has no problem in her life, but she feels the need to keep on doing these things over and over again for no reason. It's also not because of the fact because she seeks attention. That's also not the reason. People like people who are into drugs and with these type of things, with these type of personality disorders, keep in mind that they are not doing this to seek attention. It's just a disorder of their personality. Okay. And to people like Jean, she has another major problem. Her problem is when a guy is good to her. Okay. When this guy is good to her, okay, let's say this guy gives her a flower. Okay. She would fall for this guy, and this guy is the best guy in the world. Okay. There's nothing, no one is better in the world than him. But let's say Gene calls this guy for a phone call, and this guy is on his phone. Okay. And this guy cuts Gene's calls because he's on an important call himself. Then Gene has nothing to say but bad words to him, and he's the worst person in the world. Okay, there's nothing, there is no one worse than him. Okay, what type of defense mechanism is this? Splitting personality. So I mean, splitting the defense mechanism. Very good. And the personality disorder which Gene has over here is called borderline borderline personality disorder. Borderline personality disorder. Okay, borderline personality disorder. Have you guys understood this problem? Have you guys understood this problem? Okay. Next one. Well, what is the next one? The next one is I want to talk about another woman over here. Okay. Please keep in mind when I'm talking about men and women in different types of stories. Okay. I'm not um, I'm not directing the stories or my thoughts to these people. Okay. Men and women alike. It's not like men cannot have borderline personality disorders. Men can also get borderline personality disorders. But according to your text, borderline personality disorder is more common in females than males. So that's why I'm using the different types of sexes for different types of personality disorders. Okay, next one is you have another female over here. Okay, you have another female over here. Okay, so everything in her life is also going great. Okay, but and she's actually pretty well educated. She has no problems with she has no problems with her education or problem or there's nothing wrong in her family. Okay, but for some reason she always feels the need to seek attention. How does she do that? Okay, let's say that she walks to a bar. Okay, let's say that she walks inside a bar, and that's completely okay. She's walking inside a bar. She wants to go and have a good night. She wants to grab a couple of drinks, and then she wants to go out. And that's how a normal person would act. When she would go inside a bar, she would start shouting. Let's say she starts talking to someone, she's so loud that she wants everyone around her to hear what she is talking about. So she's seeking attention. Okay. Then she keeps on talking about the fact of how things in her life is not okay. Everything is a problem. Her boss is being like this. Her boss is being like that. Like that. Okay. She's being extra dramatic for no reason. Okay. She's being extra dramatic for no reason. After that, after that, okay, there is one guy in her life. Okay, that guy is pretty well educated. He loves her a lot, but she does not like that guy because that guy has a big belly. Okay, that guy has a big belly. Okay, she is into guys, okay, have who have abs, okay, has muscles. Okay, does not matter how that person is. She's into these type of people. So she is pretty shallow. Okay, she is pretty shallow. Another one is, another one is, she is sexually provocative. What do I mean by sexual provocativeness? Meaning that she wants to use, she wants to use, okay, she wants to use approaches with her body language in order to get away with things. Okay, and not in order to get away with things, with absolutely anything and everything. That's how she acts. Keeping in mind that she does not have to act like this. She does not have to need, she does not need a lot of attention because no one really cares. She does not have to be really dramatic because once again no one really cares about her dramas. Okay, everyone has their own problem in their life. Next one is she does not have to be so shallow because these guys over here, they will not be there for her, whereas this guy over here, although he has a big belly, he really loves her. He's going to be with her for the rest of his life. So that's that. And the next one, last one, is she is sexually provocative. She doesn't have to be sexually provocative. She can just do whatever she wants because the world is the same for everyone, more or less. Okay, so that's that. This person over here with all of these problems, this is histrionic, attention seeking personality. Histrionic personality. Okay, are we clear about histrionic personality? Histrionic personality. Okay. Okay, good. Okay. Next one. Next one is, okay. Next one is, I want to show you a picture of this next guy over here. Okay. Okay. This guy over here, uh, Donnie Trump. Okay. Okay. So this friend of mine, he has a big problem. What his problem is, this guy, he has a delusion of grandiosity, meaning there's no one in the world who's best. He's the best. Okay, there's nothing in the world that is best. Absolutely everything is amazing to him. Okay, there's no problem in the world which he cannot solve. Okay, he has a sense of entitlement. Okay, his problem is he feels like the world owes him everything. Okay, so he made the world a better place and now the world owes him everything. That's his second problem. Third problem is if you ever come to him with any of your problems, he will not show any empathy. He lacks empathy. Okay, and his fourth problem is he loves admiring himself. Okay, he looks at himself in the mirror. He has a tan. He puts his tan on. Okay, he loves combing his hair. Okay, and he often uses the word best. Everything is the best. That's the best thing in the world. Okay, so that's that. This friend of mine, okay, he's the president of the United States. His problem is he has, okay, what is his personality disorder? What is his personality disorder? His personality disorder is narcissistic. Narcissistic. Narcissistic personality disorder. Okay. Are we clear on Donnie Trump? Okay. Narcissistic personality disorder. Okay. Have you guys ever seen his speech? Have you ever seen him talk in okay, have you guys realized that he uses the word best a lot? Best, that it's the best, everything is the best for him. Okay, best in the world. Okay, yes, that's the thing. So I'm sure it even says on your first date that the people who are people who are very narcissistic, they will keep on using the word best, best, everything is the best, he's the best, whatever they do is the best. Okay, so that's your narcissistic personality disorder. Okay, next one. Next one I want to go to is okay. Okay, next one I want to go to is cluster C personality. Okay, next one I want to go to is cluster C personality. Cluster C personality. Okay, cluster C. Okay, what is cluster C personality? First of all, cluster C personality, number one, these people, okay, these people, they're actually very nice people. The problem with these people are, problem with these people are that they are very shy. They're very shy. They're very sensitive to get rejected by other people, so they do not approach other people. Okay, they cannot stand up for themselves, nor can they stand up for anyone else. Then they want to have a relationship, but they're too scared to make the first move. Okay, if there's something going on, if there's a crime in front of them, instead of reporting that crime, they will act very cowardly. Okay, and in fear of being criticized, they will not do much in order to be criticized, in fear of being criticized by someone. Okay, so these people over here who avoids all situations because they have a problem, their personality is avoidant personality disorder. Their problem is they have an avoidant personality disorder. Okay, next one. Next one is next one is another patient. This guy, okay, he feels the need to switch the okay, he feels the need to use the switch 5 times before before he comes out of the room, because he firmly believes that if he don't switch the light switch off and on 5 times, one of his family members will die. And he does this obsessive repeated compulsive moves over and over and over again till it causes him functional impairment. This problem with this guy, their personality is obsessive compulsive personality disorder. It's not an obsessive compulsion, it's not an obsessive compulsion disorder. It's an obsessive compulsive personality disorder, meaning that these guys, they will not have a problem with the light switch on and off as much. But the main problem with these people are, let's say they have a bed. Okay, they will wake up in the morning and then they will make the bed, and the bed has to stay exactly how it is. No one can come and sit on the bed. Okay, because the bed cannot have any creaks, any lines, because it's normal to for the beds to have some sort of creaks and lines. And if someone comes and sits on the bed, that's completely fine, because the bed is meant to sleep or sit or do whatever. But to these people, the bed has to be a certain way. Okay, the couch should have the pillows in a certain way. Okay, the table in front of the couch has to be at a perfect distance from the sofa. The lamp over here has to be perfectly in proportion. Okay, these people have obsessive compulsive personality disorders. Do you guys remember Monica from Friends? Monica. Okay. So if you guys have seen Friends, Monica from Friends have a severe obsessive compulsive personality disorder. And once again, do you guys remember Phoebe? Phoebe. Okay. Phoebe has a schizotypal personality disorder. Okay. Do you guys remember Ross when Ross was a teenager? Ross was a teenager, how he never had the guts to go up to anyone and ask for advice. Avoidant personality disorder. Okay. Avoidant personality disorder. Okay. Dr. Mohammed Abu Riyash. Okay. Dr. Mohammed Abu Riyash. Is it possible for you to send us give us your email address? Give us your email address so that we can send you an email. Oh, okay. Are you friends with Dr. Hussam? Okay, so you're a friend of Dr. Hussam. Okay, good. Okay, okay, all right. Okay, no problem. Okay, good. Okay, let's talk about our last personality disorder. Let's talk about our last personality disorder. Okay, okay. The last personality disorder is you have and this one guy over here. Okay, this guy over here has no self-confidence. He does not believe in himself. Okay, he has no self-confidence. Okay, cannot stand up for himself, nor can he stand up for anyone else. He's always very clingy. He has a wife. That's not the problem. He has a wife, but he needs his wife to do everything for him, or he wants to do everything with his wife. Let's say he wants to go and eat something. He would need his wife to go with him, even though his wife doesn't want to eat. Okay, then let's say he wants to watch a movie. He can just watch the movie by himself, but he would need his wife to go and watch the movie with him. Okay, and these people, okay, these people, they cannot stand up for themselves, nor can they stand up for anyone else. But these people are so dependent on the wife or someone else that even when the wife abuses him, okay, let's say the wife physically abuses him, hurts him, okay, or emotionally or verbally abuses him, he takes all that abuse because he needs her. Okay, he takes all that abuse because in his mind he is dependent on her. Okay, and no matter what she does, she's always right, he's always wrong because he has no self-confidence. So that's that, he cannot stand up for himself. This guy over here, his problem is his personality is dependent. Dependent personality disorder. Okay, his problem is he has a dependent personality disorder. Are we clear on dependent personality disorders? Okay. Okay, now, um, okay, now, difference between borderline and histrionic. Borderline people will not seek attention. Okay, borderline people will not seek attention. They are out there to destroy themselves. Okay, drugs, party, suicide, okay, killing themselves. OCD and OCD personality disorder. OCD is being completely obsessed with a certain repeated movement all the time. Okay, trying to okay repeat. They will try to switch the light off and on 5 times. That is absolutely abnormal, and they will do abnormal things. That's obsessive compulsive disorder. Obsessive compulsive personality disorder is everything has to be in the right way. Okay, everything has to be in the right way. Okay, the world has to be perfect. That type of personality is obsessive compulsive personality disorder. Borderline personality disorders are people who have a perfect family and everything is okay, but they still feel the need to go outside, okay, have drugs and alcohol, come back home, create a mess, make suicidal thoughts, cut themselves, be in meaningless relationships. Okay, these are your people with borderline personality disorders. Rude to other people. Okay, are we clear about borderline personalities, OCDs, and obsessive compulsive personalities? Yes or no? Okay, are we clear? Okay, good. Now, can you guys tell me really quick, well, what are the cluster A personalities from the stories which we just discussed? Cluster A personality. Who are the people with cluster personality? Paranoid. Then paranoid. After that, schizoid, schizotypal. Very good. Next one, cluster B personality. Cluster B personality. Number one. Number one. Cluster B. Number one, antisocial. Number two. Number two, borderline. Number three. Number three, histrionic. Four, histrionic. Narcissism. Okay, Donald Trump. Okay, cluster. Do we have any Trump supporters in the? If we do have any Trump supporters, okay, I apologize. There's nothing I have against your president. Okay, you are at absolute liberty to support whoever you want to support. Okay, I personally don't support him. That's my decision. Okay, but having said that, even you have to admit, if you're a Trump supporter, that your president is very narcissistic. Okay, okay, just putting it out there. Now, cluster C personality. Cluster C. What are the cluster C's? Avoidant and obsessive compulsive. So have you guys understood all the term personality disorders? Good. Okay, good. Great. Okay, good. If that's what it is, then let's keep on moving forward. Okay. 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 Let's keep on moving forward. First and foremost, okay, I want to talk about some terms over here which will overlap with one another. So we're done with all these. Okay, we're done with cluster personalities and this and that. Okay, next one. Next one is what I want to talk to you guys about is malingering, fictitious disorder, and somatic symptom disorder. Okay, okay. First and foremost, we want to talk about some things. Okay, have you guys seen people that whenever something traumatic is going on in their life, they kind of lose consciousness and they just lie down, or they just fall on the floor for no reason? There's absolutely nothing wrong with them. It's not even a simple attack. It's not a heart attack. Everything is okay, but they just feel the need to they just feel the need um, to seek attention or do something in most cases. Okay. Okay. Having said that, have you guys ever heard or seen patients like this in your life? Have you guys dealt with these patients? Okay. Okay. Okay, good. So the thing is, at the end of the day, I know that a lot of physicians, they do not like when you have a very busy hospital. Let's say you have multiple patients with appendicitis, and then you have one hysteric patient like this. Okay, I know that you are not supposed to. I know that these patients with hysteria, they're supposed to piss you off. Okay, why? Because you have to deal with so many other real problems, actual problems where people have appendicitis and this and that, and those are an issue. Okay, but are people with hysteria not your are hysteria are people with hysteria, are they not your patients too? Yes or no? Patients, it does not matter if they have hysteria or if there's something wrong with them, or if something is bothering them, and then and I mean they are trying to act like something. God knows what the problem is, but as long as they are under you, as long as you are supervising them, they are your patients. So it's your responsibility to deal with them. The reason why I'm talking, the reason why I'm saying this, it's I want to raise awareness for doctors not treating patients with hysteria, as well as all the other patients, because hysteria is still a problem. Hysteria is still a problem. Okay, so you have to, you, even though what you can do is you can triage the patients, obviously deal with your patients who need more care first, and then come back to your hysteric patient and deal with them too. Okay, don't try to shout at them, don't try to scold them, or don't try to use any other methods to cure to keep them out of their hysteric episode. Okay, so that's that. Hysteria, people with hysteria or these type of people are also real patients. Okay, they also need your real care. But first and foremost, in order for you to do that, you have to understand what is malingering, what is factitious disorder, okay, and what is a somatic symptom disorder. What is a somatic symptom disorder? Okay, right now we have entered our task once again. Okay, first of all, there are two things that you have to know. First are the symptoms, then is the motivation. Okay, motivation. But and what do I mean by symptoms, and what do I mean by motivation? First and foremost, symptoms meaning that the patient will actively uh, choose to have symptoms. Let's say you are a normal person, you do not have any symptoms right now. If you want to malinger or do anything, your symptoms will be that you, well, let's say you are arguing with your partner, he says something that you really don't want to hear, or that really upsets you. Okay, you start acting extremely dramatic, and then you act like you are losing your consciousness, and then you fall on the floor so that he can come up to you and ask you, oh, hey, what happened, are you okay, look, whatever. Okay, so that's the, so those are the symptoms. And right now for these people, symptoms are intentional. They're intentional symptoms, meaning that they know they are doing these symptoms. Okay, symptoms are intentional. Motivation meaning that they decided to do this act. They decided to do this act. Okay, so the motivation for this is also intentional. Okay, the motivation is also intentional. Okay, so you are in complete consciousness, you have decided to act like this, and so you act like this. Okay, and your motivation is intentional and your symptoms are intentional. So people with symptoms whose symptoms are intentional, whose motivation is intentional, these people, they fake. Okay, they fake, exaggerate, or they claim to have a disorder, or they claim to have a problem because they want something out of this. What do they want? Maybe they want some kind of a secondary gain. Okay, secondary gain, that's what they want. That's what you have to figure out as a physician, that what do you really want, what is your problem. That is your goal of treatment. Your goal of treatment is to find out what they want and then see whether you can or cannot give it to them. Let's say if they have these type of actions in the office, let's say that they act like this in front of their boss. Obviously their boss is not a physician. Their boss will, obviously what they do is they'll be like, okay, you know what, take 2 days off, take 2 days off work, I will pay you, it will be a paid leave. And his or her secondary gain was to get paid leave. So that's their secondary gain. So they usually have a secondary gain for which they are doing this. Okay, and the next thing is, if you as a doctor, if you want to treat them, their compliance with the treatment will be very poor. Okay, their compliance with the treatment will be very poor compliance. Why will they be poor compliance? They will have poor compliance. That's because they know there's nothing wrong with them. They know that they are completely okay, there's nothing wrong with them. They will believe that the doctor does not know what's going on. Okay, they do not know that doctors are, and that doctors like understand what malingering is. Okay, so they would think that the doctors are prescribing me medications for no reason, I'm completely okay, so they will not be compliant to treatment or follow. Okay, and after they get what they need, let's say that they needed the paid leave, everything will disappear. The symptoms will be okay, the motivation will disappear. Okay, these problems are known as malingering. These problems are known as malingering. Okay, this is your malingering. First of all, in malingering, symptoms are intentional, motivations are intentional. They usually have a secondary gain, and they're poor compliant. Okay, have we understood malingering? Yes or no? Okay. Okay. Next one. Okay. Next one I want to talk about is next one I want to talk about is these patients. Okay, their symptoms are intentional. Okay. Okay, symptoms are intentional, but their motivation, they do not know why they are doing this. Okay, their motivations are unconscious motivations, meaning that they are not aware why they, okay, they are not aware that why they need to act like this. The first problem with malingering was they knew, I mean, let's say this guy, okay, he wanted to get paid leave. So he knew that if he goes, then he falls sick in front of his boss, okay, he will get that paid leave. That's a secondary gain. Okay, so his motivation was intentional, his symptoms are intentional. His symptoms were intentional. But right now, this lady over here, okay, this lady, she does not know why she feels the need to be unconscious. Okay, so her motivation is her motivation is unconscious motivation, meaning that she does not know why she feels the need to fall on the floor or to act like there's something wrong with her. Okay, she does not know why she has these sorts of motivations. But one of the primary reason that she wants this kind of attention, or I mean, attention is not the right word. The primary reason why she wants this sort of she acts like this way is because instead of having a secondary gain, these people, what they want is they want a primary gain. And primary gain is two things: medical attention and sympathy. Okay, they want people to sympathize them. They want people to sympathize them. They want people to give medical attention to them. Okay, and they do not know why they have these sorts of needs. They do not know why they need like this. Maybe they're alone, maybe there's something wrong, but she cannot point it out. Okay, it's your job as a physician to find it out. But the first and foremost is they will act unconscious. So their symptoms are intentional, but they do not know why they have to act like this. And their reason is they want a primary gain. They want a primary gain. Okay, so this is known as factitious disorder. Factitious disorder. Okay, and what happens is when you do the medical attention and you show sympathy to the patient, okay, and let's say this patient comes into your clinic and she's acting like this, okay, and you act with her in a very nice way, and you tell her, okay, do not worry, I'm here for you. Listen to all the questions and problems you have. Please wake up. And then all of a sudden she'll start waking up, and then she'll tell you that what her problem is. Maybe she has some sort of a stupid tummy ache and this and that, which makes no sense. Okay. But you have to give your proper medical attention to these patients, because at the end of the day, they are still your patients. Okay. So, and once you do that treatment, then these patients will be okay. They will not come back. Okay. They will not come back. So that is that. Okay. Now there are two types of factitious disorders. Factitious disorder. Number one, factitious disorder on self. Okay. Factitious disorder on self. Okay. Meaning that factitious disorder on self is exactly this scenario over here, meaning that you are factitizing the disorder on your own self. Okay, so this is also called Munchausen syndrome. Okay, this is also called Munchausen syndrome. Munchausen syndrome. And this is completely okay. You're not harming anyone. Okay, you're not doing anything. You just want love and attention and sympathy. So you're acting like this, but you do not know why you need the love and attention. Okay, so that's your factitious disorder on self. Next one is factitious disorder. Factitious disorder on someone else. Someone else. Okay, and this is a very dangerous thing. This is called Munchausen syndrome by proxy. Proxy. Okay, Munchausen syndrome by proxy. What is Munchausen syndrome by proxy? Okay, this is when a caregiver, okay, let's say you are a caregiver, you're caring for your son or you're caring for your old father. Okay, you are the caregiver and you are the one who is harming these people. Let's say, okay, you're the one who is harming these people, but even the son, not the father, knows that you are the one who is poisoning them. Okay, let's say that you are poisoning your son, let's say that you're poisoning your father. Why are you doing this? You are doing this, okay, you are doing this to to assume a sick, okay, to assume a sick proxy role. Okay, you love the fact that when you take them to the hospital, you love the fact that you when you take these people to the hospital, the physician can come and thank you and tell you that, okay, thank you so much for bringing your son to the hospital or your father to the hospital. Do not worry, we will take care of them right now. And that's the sort of attention that these people like. Okay, these people are very, very scary. That is called Munchausen syndrome by proxy, and these are your poisoners of the people who are given care to. Okay, so they're the caregivers who poisons other people. This is factitious disorder on someone else. Are we clear? Okay, we so many questions. Okay. Okay, who has confusions? Doctor, there are questions. This is all mixing up, so confusing. Okay, doctor, could you repeat? It's different. Okay, one by one. What is your question? Factitious disorder on himself. Please repeat. Okay. Factitious disorder, or meaning that the patient has, the patient does not know why the patient needs attention. So the motivation is unconscious. So the patient assumes to fall sick. Okay. First and foremost, who are the students who has the questions? Please let me know right now. First and foremost, what who are the students who has the questions regarding these topics? I'll clear it right now. I'll clear all the questions right now. Okay. Okay. So let's talk to each and every one by one. Okay. So we have 3 or 4 questions, and it's completely easy. I'll make you understand the whole thing. Number one question from Dr. Nadine: what's the difference from malingering? Okay. What's the difference of malingering from which term? Which term? Malingering from which one? How do you want to differentiate malingering? Fast answers, please. How do you want to differentiate malingering? Factitious from malingering. Very good. Okay. First and foremost, people with factitious disorders, they have intentional symptoms. Okay. People with factitious disorder, they have intentional symptoms, but their motivation is unconscious. People with malingering, their symptoms are intentional and their motivation is also intentional. So they know they want, okay. Dr. Nadine, can you hear my voice? Can you hear my voice? Dr. Nadine. Okay, good. Okay, then listen to me very attentively. Okay. Okay. First and foremost, you have a person. Okay. You have one person who wants to take a paid leave from work. Okay. If he goes and acts sick in front of his boss, if he goes and acts sick in front of his boss, will the boss give him or her the paid leave? Yes or no? Dr. Nadine. Yes. Okay. So is this a primary gain or a secondary gain? Primary gain or a secondary gain? Gain. Primary gains are usually attention, love, sympathy. Secondary gains are usually money. Okay. Then uh, vacations. Okay. Secondary. Yes. So it's a secondary gain. So these people who are acting sick in front of their boss to get a secondary gain, these people, what they are doing is they are malingering. Are we clear? Are we clear? Dr. Nadine? Yes or no? Okay, good. Now you have another people, and now you have another person who does not, who is very lonely. Okay, who is very lonely. So what they do is, who is very lonely at their house. They do not have anyone living with them. Okay, so in the middle of the night, they come to the emergency department, act unconscious. They act unconscious. They do not know why they have to act like this. But once the physician talks to them in a nice way, the patients get okay. So if the physician shows a little bit of love and sympathy, then they get okay. What is this disorder? For the primary gain, what is this disorder? Fast answers, please. Factitious disorder. Okay, this is factitious disorder. Okay, hope that clears the difference between factitious disorder and malingering. Does anyone else have any other questions? What was the next question? Difference between OCD and obsessive compulsive. Once again, please pay your attention. Once again, if a person switches the light switch 5 to 6 times, for example, before leaving the room, because he believes that if he does not do it, someone in his family will die. Okay, so this is very ego dystonic. Okay, this goes against his belief because that will not happen. He knows no one will die, but he's going against his own belief. This person has obsessive compulsive disorder. And obsessive compulsive personality disorder are people who want things done in a certain way all the time. Okay, they want the house to look a certain way, they want everything to be perfect. Okay, perfectionists. Obsessive compulsive personality disorder. Are we clear? Okay, good. Any other question? Next one. Is factitious like hysteria? Yes, factitious is like hysteria. Okay. There is no word in first aid which says hysteric convulsion reaction, like the words which we use back in our bachelor's. Okay, hysteric convulsion reaction. There's no word like this. God knows who came up with it. But you have malingering, factitious, and somatic symptom disorders. Okay. Any other question? Any other question from anyone else? Absolutely anyone else. Okay. So, having said that, are you guys all clear on the malingering factitious disorder? Okay. Yes, very high yield. Yes, very, very high yield. Okay. None of the things which I'm talking about right now are less yield. Okay. Everything about psychiatry is high yield. Everything about psychiatry is high yield. Okay. So, if I tell you that you are assuming to be sick in order to gain attention, is it factitious disorder on self or on someone else? Fast answers on self. If I tell you that you are poisoning your old father at home because you want the doctor to thank you bringing you to the hospital, factitious disorder or Munchausen syndrome proxy. Okay, good. Okay, next one. Okay, next one. Next one I want to talk to you guys about is somatic symptoms. Okay, next one I want to talk to you about is somatic symptom disorder. So next one I want to talk to you about is somatic symptom disorder. Okay, okay. Somatic symptom disorder. Somatic symptom disorder. First of all, in somatic symptom disorder, you once again you have the symptoms, then you have the motivation. Okay, so first you have the symptoms, then you have the motivation. For symptoms, these patients, the symptoms are unconscious symptoms. Okay, for example, these people they will have some sort of a bodily complaint. Let's say they will talk about the fact that my stomach has been hurting for the last 1 month, or my stomach has been hurting for the last 3 years. Okay, in reality, is their stomach really hurting? The answer is yes. Okay, the answer is yes, their stomach really is hurting. Okay, they're not lying, they are really hurting. But why is the stomach hurting? No one knows. Okay, there's no organic cause for the stomach hurt. Everything in their anatomy and physiology is okay, there's no pathology. The only problem is the stomach hurting, they do not know why they're hurting too, so their symptoms are unconscious. They do not know why they have a stomach ache. At the same time, they're also not telling you that they have a stomach ache because they want a primary gain or they want a secondary gain. They have no idea why their stomach is hurting. Okay, so their motivation is also unconscious. Okay, so they do not want any sympathy, love, or paid holidays or anything else. Okay, they just have a somatic symptom. So the thing is, these patients, once you diagnose a patient with somatic symptom disorder, the treatment is very easy. The treatment is regular follow up. You ask the patient to come to the office regularly. Okay, so what this will do is whenever they come to the office, the clinics regularly, and they get a checkup, they will realize that at one point they will realize there is nothing wrong with them, and they can be reassured that everything is okay with them. So when they understand that everything is okay with them, their symptoms will disappear and their motivations will also disappear. Okay, are we clear on somatic symptom disorder? Are we clear on somatic symptom disorder? Yes or no? Okay, that's that. Okay, next one. Next one is, okay, next one is conversion disorder. Okay, next one is conversion disorder. Okay, what is conversion disorder? Conversion disorder is, once again, this is the type of patients that we find back, which are known as HCR or hysteric conversion reactions. Okay, but nowhere in first aid does it say that patients are hysteric. Okay, so these are called conversion problems, conversion disorders. These people, what they have is they have a functional neurological symptom. Okay, what happens is they lost, they lose, they lose sensory and motor function. They lose sensory and motor function, meaning that they act like they're paralyzed. Okay, when they hear a bad news, acute stressor, there's something that is stressing them out. That is the difference. Okay, there has to be a stressor. Okay, something has to go wrong. There has to be one sort of a stressor which should happen. After that, the patients lose their sensory and motor function. This is known as conversion disorders. This is known as conversion disorders. Are we clear? Have you guys understood? Yes. Yeah. Have you guys understood conversion disorders, infectious disorders, and okay? Why do people do malingering? Again, fast answers, please. What is the primary reason for malingering? Malingering. Second, why do people have factitious disorders? Fast answers, please. People have disorder. Primary gain. Okay. Can you guys hear my voice? Okay. Can you guys hear my voice? Can you guys hear my voice? Okay, good. Right. So why do people do disorders? Factitious disorders. What is the main cause of factitious disorders? Fast answers, please. Primary gain. Good. Good. Okay. Now let's talk about somatic symptoms disorder. If we want to have a somatic symptom disorder and it's a conversion disorder, what is the main problems? Stressor or not a stressor? Stressor or not a stressor? Stressor. Okay. Do we need stressors for factitious disorders? Do we need stressors for, okay. Do we need a stressor for malingering? Do we need, okay, good. Okay. Do we need a stressor for conversion disorder? Yes. Okay. Yes. Yes. Yes, we do. Okay. That's what it is. Okay. Okay. Have you guys heard about hypochondria or hypochondriacism? Okay. Illness, anxiety disorder. Illness, anxiety disorder. Okay. Do you know what illness, anxiety disorders are? This is the disorder which you had in your third year. Do you guys remember that you had this problem when you were learning about peptic ulcer disease or something? You guys thought you had peptic ulcer disease. Okay, most common in medical students. Okay, you think you have them. Okay, I was convinced I had brain cancer from a personal experience. I was convinced I had brain cancer, and I went to so many people. I went to our neurologists. Okay, after I was assured that I do not have brain cancer, and the only thing left for me to do was do a CT scan or MRI, because no one could reassure me that I did not have brain cancer, because I started having symptoms such as morning headaches, vomiting. Okay, and I realized all of these things were happening because I was staying up late watching TV series. Okay, I was staying up late watching TV series and trying to catch the morning classes, and every day I would wake up in the morning feeling absolutely horrible. Okay, I would have a headache. I would have um, vomitings. Okay, because I would be, and then at the same time, everything started making sense. Okay, and it went side by side with the sign symptoms of brain cancer. And the worst thing which you can do as a medical student is try to Google your sign symptoms. Have you guys ever Googled your sign symptoms? Have you guys ever Googled your sign symptoms? Are you guys ever going to Google your sign symptoms ever again? No. Okay. Okay, good. Do not ever Google your sign symptoms. Okay. Okay, so that's what it is. Conversion disorder. What is conversion disorder? Conversion disorder is when you have a stressor in your life, and then all of a sudden you start to act like you have no sensation or motor control over your whole body. That is conversion disorder. Okay, how do you treat a patient with conversion disorder? You address the underlying stressor, and you tell them that it's okay. Like everyone has problems in their life, and you have to deal with it. And when they understand that the stressor is not stressful anymore, the conversion disorders will disappear. Okay, that is conversion disorder. Somatic symptom disorder are the disorders in which the patients do something for a primary gain, for example, love or sympathy. So they act like there's something wrong with them when there's not. That is Munchausen syndrome. And then they either that, or they act like or they try to create harm on the people they care for, so that when they're taken to the hospital, they can be shown love or sympathy there. Next question: for how long the patient will have conversion disorder, or is this a specific time? There is no specific time. The patients can have conversion disorders throughout their whole life. Okay, that's just a state of mind. Okay. Anyone else? Any other question? Oh, somatic symptom disorder. Which one do you want to understand? Somatic symptom or fictitious? Which one? Somatic symptom. Okay, somatic symptom. In somatic symptom, the problem is this in somatic symptom, the problem is the patients have an unconscious symptom, and the motivation is also unconscious. Okay, and in factitious disorder, the patients have symptoms that are intentional, but the motivation is unconscious. Okay, let me break it down once again. If a person comes to you and tells you that he has a stomach ache, okay, for the last 1 year. Okay, he has a stomach ache, and he has a stomach ache for the last 1 year, and you do not, and you do all the tests in the world to realize what the problem is, but you do not find anything. Okay, does the does the person really have the stomach ache? Yes or no? Does the person really have the stomach ache? Yes, they really do have the stomach ache. They really do have the stomach ache, but they do not know why they have the stomach ache. So once you figure out that there's nothing wrong with them, that the endoscopy is okay, the ultrasound is okay, okay, and then the CT scan is okay, there's no functional problem with the patient, then you conclude that this patient has somatic symptom disorder. Okay, and then you tell them that you have no problem in your stomach, although it's hurting. We understand. What you have to do is you can come back and be on follow-up with us, and when the patient stays on follow-up, the patient can get assured that the patient has no problem, and the patient can get treated. This is somatic symptom disorder. What is factitious disorder? Factitious disorder is basically the the patients, they usually want a primary gain. That is, they want love or sympathy. So what they do is they act in a certain way that they tell you that there's something wrong with them so that you can show them some love and sympathy. And when you do that, they feel okay. That is Munchausen syndrome. And Munchausen syndrome by proxy is when the patients care for someone else, they harm that other person so that they can show the people how much they care for them when they bring them to the hospital. That is Munchausen syndrome by proxy. Okay, are we clear now? Are we clear now? Okay, perfect. Any confusion? Do you guys want to take a break before we move on, before we keep on moving forward? Okay. Okay, how long do you guys want to take that break for? 15 minutes. Okay. We'll take a break for 10 to 15 minutes. Oh, okay, are we back from the break? Is everyone back from their break? Is everyone back? Is anyone back from their break? Okay, 2 minutes. Okay. Okay, so we're going to start right now. Okay, so we're going to start right now. It's been 12 minutes since we had the break. Question, so conversations patients are 4x after stress removing the... Okay, what was your question, Dr. Hassam? I did not understand the question. Can you please rephrase your question? Okay, so we will move. Okay, the symptom they can have. Yes, blindness or so whatever symptoms they have, if you remove the stressor, the symptoms will go away. Okay, okay, good. So let's start with our second problems. Okay, let's start with our second disorders. Is everyone back? We're going to start right now. Okay, then let's begin. Let's begin. And okay, the symptoms that we want to talk about, the disorders that we want to talk about right now are eating disorders. Okay, so we have two eating disorders that we want to talk about. First of all, we want to talk about anorexia nervosa. Then we want to talk about bulimia nervosa. Okay, anorexia nervosa and bulimia nervosa. So what is anorexia nervosa? So let's go back to our page over here. So okay, first let's read the text and let's go back to the page. There are things to look out for because over here, this is one of those texts in first aid which is important. Okay, this is only the blank page will not do. For anorexia nervosa, we have to read this. First of all, what is anorexia nervosa? This is an intense fear of weight gain. So these are people who have intense fear of gaining weight. They over evaluate their thinness, body image, leading to calorie restriction and severe weight loss with inappropriate low body weight. Their body weight is really low. So for people with anorexia nervosa, their main thing is, will they have high BMI? I mean, normal BMI or less than normal BMI? Will they have a normal BMI or less than normal BMI? Low BMI. Okay, they will have a low BMI. Now, there are types of anorexia that is binge eating or purging type. What is the binge eating or purging type? Binge eating meaning that they will have recurrent purging behaviors, meaning that purging meaning vomiting. Okay, so they will have vomiting. Either that's a type of purging, or they can also have laxative to cause diarrhea, so that the food they eat can leave their body without causing the weight gain. Okay, so this in turn will, what will do is this will cause a loss in BMI, or low BMI. Okay, so the binge eating, these things, they can last for 3 months. So that is a binge eating type of anorexia nervosa. Next one is restricting type. Restricting type is primarily disordered behavior, which can include dieting, fasting, or over exercising. And these people will over exercise to lose, to look a certain way, to feel a certain way. Okay, so that is anorexia nervosa, restricting type. Okay, that is the restricting type. Restricting type meaning that they will have certain types of behavioral changes, such as dieting or fasting. Okay, that is the restricting type. Next one. Next one is refeeding syndrome. Refeeding syndrome, this occurs in significantly malnourished patients. And what will happen is these patients can have increased calorie intake. As a result, their insulin will increase, and there will be a problem with their phosphate, potassium, and magnesium. Everything will get down. Okay. Now, my main concern is, if you have to diagnose binge eating type of anorexia nervosa, if you have to diagnose binge eating type of anorexia nervosa, and you have to diagnose bulimia nervosa. Bulimia nervosa is also a recurrent type of binge eating with purging behavior. Which one of them will have a normal BMI? Which one of them will have a normal BMI? Very good. Okay, very good. The patients with a normal BMI are the one with bulimia nervosa. The patients with bulimia nervosa will have an absolutely normal BMI, and the patients with anorexia nervosa will have decreased BMI. Okay, their BMI will be decreased because their disorders are related to fasting, dieting, and uh, okay, that's that. Okay, and now let me explain the types of anorexia nervosa. First of all, you have the binge eating type. What is binge eating? In binge eating, you will have recurrent purging behaviors. Okay, recurrent purging behaviors. What is purging? Purging is, once again, either vomiting or diarrhea. Next one is restricting type. Restricting type is over exercising. Over exercising, or over evaluation type. Next one is refeeding syndrome. Next one is refeeding syndrome. Refeeding syndrome is sudden increase in calorie. They have not eaten for a long period of time, and all of a sudden, they eat a lot, increase eating. This is known as the refeeding syndrome. What happens when you don't eat carbohydrate for a long period of time, and then all of a sudden you eat carbohydrate? Does your normal insulin increase or decrease? Insulin level all of a sudden increase. If insulin increases all of a sudden, will that cause your electrolyte imbalance? Yes or no? Yes. Okay, they will cause electrolyte imbalance. So these are the three types of anorexia nervosa. Are we clear on anorexia nervosa now? Okay. So first of all, what is anorexia nervosa? Anorexia nervosa, the BMI. BMI is low. Patients, they do not eat a lot. They work out a lot. Okay, they are worried about their body image. So just focus on the BMI. No matter what happens, focus on the BMI. If the BMI is low, then the patients have anorexia. Okay, it's not high yield to understand what type of anorexia this is. Just make sure that for eating disorders, the BMI. Okay, in your question, if they explain to you about a patient who has a low BMI, then they have anorexia. Next one I want to go to is bulimia. Bulimia is basically, in bulimia, BMI is normal. Normal BMI. Normal BMI meaning, first of all, BMI is body mass index. Okay, this is a measurement of your overall weight to height ratio. Okay, so body mass index. So BMI, if it's a normal BMI, meaning that the person is not obese, or not the person is underweight. So do you guys know what the normal level of BMI is? What is the normal level of BMI? Fast answers, please. Right. Well, 18.5 to 24.9 is the exact answer. So That is that. So thank you, Dr. Hassan. So BMI is normal for these patients. So in bulimia patient, the only thing that you have to focus on for you world is BMI. If BMI is normal, then the patients have bulimia. Try to understand that bulimic patients will also have purging behavior, that they will try to vomit after they eat. So what will happen is when they try to vomit, their parotid glands, okay, their parotid glands will have hypertrophy. Parotid gland hypertrophy. Okay, hypertrophy of the parotid gland. Okay, that's number one. Number two is when you vomit a lot. Okay, this can cause enamel, dental enamel erosion, dental enamel erosion. Okay, another thing that can happen is when you vomit a lot. Can this cause tear in your esophagus? Yes or no? Can this cause tear in your esophagus? Yes. If you have a tear in your esophagus due to vomiting or retching, what is the name of this condition? Fast answers, please. Mallory-Weiss syndrome. Very good. So patients can also get Mallory-Weiss syndrome. Mallory-Weiss syndrome. Okay. After that, okay, patient can also get Mallory-Weiss syndrome. And another thing is the patients use their hands. Okay, so let's say that this is the patient's mouth, and they will use two fingers in their mouth to induce the vomiting. Okay, they will put the fingers in their mouth to cause vomiting. So these fingers over here, what they will have are calluses. They will have they will have dorsal hand calluses. Let me show you a picture. Okay, like this. Okay, that's that. So they will have dorsal hand calluses like these. Again, like these. Okay. So that is known as, so these are, along with all of this, if I have to talk about electrolyte abnormality, if you vomit all the time, will you have metabolic acidosis or metabolic alkalosis? Will you have metabolic acidosis or metabolic alkalosis? Alkalosis. So these patients will also have metabolic alkalosis. Metabolic alkalosis. Along with that, the potassium will be low potassium because they're vomiting, and chloride because hydrochloric acid is being lost. So chloride will also be low. Okay. Are we clear on anorexia and bulimia? Okay. Can patients with anorexia also have metabolic alkalosis, potassium problems, Mallory-Weiss syndrome, then Russell signs, parotid gland hypertrophy? Yes or no? Okay. But but like, what is the only thing that will be different, that will be differentiated between the anorexia and the bulimia patient? BMI. Yes, more or less, BMI is the only differentiating factor. That's all you have to look out for. Okay, next one. So we're done with bulimia, we're done with anorexia. How do you treat a patient with bulimia? First, psychotherapy, nutritional rehabilitation, then antidepressants, SSRI. Okay, SSRI, we give SSRI over here. Bupropion is contraindicated due to seizure risk. Why are these patients not given drugs that can cause seizure? Because these patients already have electrolyte abnormalities. So we have to use drugs that are seizure friendly. Okay, so we cannot use drugs like bupropion. Next one. Next one is binge eating disorder. What is binge eating disorder? These are basically recurrent episodes of binge eating without purging. Okay. So what happens is, let's say that you have an adult who does not eat for a long period of time, and then all of a sudden he cannot control his urges anymore, and he goes on eating and eating and eating. So he buys, so let's say he goes to somewhere like Walmart or Costco, and he buys a bag load of chips. Okay, and then instead of finishing the chips in 1 week, he finishes them in 1 hour. Okay, so out of nowhere, these guys, they start eating, and but the thing is, these guys will not vomit. Okay, there is no purging behavior. There's no purging behavior. So as a result, will these people gain weight or lose weight if they eat like this? They will gain weight. Okay, so they will have a very high BMI, then they will gain weight. They will have a weight gain. Okay, that's where it is. Okay, next one. Next one is pica. Pica or pica. Okay. Do you guys remember that we talked about pica when we talked about iron deficiency, iron deficiency anemia? Yes. Okay. So what is pica? Basically, once again, pica is basically your urges to eat food that are not edible. Example: dirt, hair, paint chips. Okay. And okay, have you guys seen the iron deficiency lecture by Dr. Hussein Sattar from Patoma? Who has seen it? Okay. When you guys saw the iron deficiency video, do you guys remember that Dr. Hussein Sattar mentions that people who have iron deficiency anemia, they try to look for iron-like taste in all other foods, which may contain iron? Yes. Okay. So that is basically what pica is. Okay. Pica is you do not have iron in your body. So basically you try to look for food which might taste like iron. So you try to eat dirt, sand, hair, and all those other things. So that is pica. Okay. Trying to source iron. That's what it is. Okay. Treatment is psychotherapy, nutritional rehabilitation, SSRI. Are we clear about pica? Are we clear about pica? Okay, next one. Next one is let's move on. Next one is gender dysphoria. Okay, next one is gender dysphoria. This is not that very high yield, so we'll just read through them. This is a significant incongruence between one's experienced gender and the gender assigned at birth. So let's say one was assigned to be a male at birth, but then throughout the life, the patient feels that patient is a female trapped in a male's body. Okay, and these feelings will last for more than 6 months, and this will cause persistent distress. The individual may identify as another gender. For example, male can identify as a female. They can pursue surgery or hormone treatment to achieve that secondary sexual characteristics. Okay, that's that. Now we have to understand what is transgender and what is transvestism. Transgender is basically desiring and often making lifestyle choices as a different gender, meaning that you were born as a male, but you make your lifestyle choices and talk, act, behave accordingly to a female. Okay, and the medical interventions may be utilized during this transition to enable this individual's appearance. Okay, so that's that. So you want you they also get uh, conversion surgeries in which they try to convert to another gender. That's transgender. What is transvestism? Transvestism is basically a perversion in which people they derive pleasure by wearing clothes of the opposite gender, okay, of the opposite sex. So they do cross dressing, and it's a type of perversion. Transvestic disorder is basically transvestism that can cause significant distress, impairment. Okay, and transvestism are basically a psychosexual or a perversive disorder, and they're not a part of gender dysphoria. Okay, so once again, not high yield. You will not receive a lot of questions from transgenderism and transvestism, not even one. Okay, so having confidence in that, let's move forward. Okay, let's talk about sexual dysfunctions. Okay, these are high yield. Okay, what are sexual dysfunctions? Sexual dysfunction disorders can be hypoactive, meaning that you can have patients with low sex drives, or sexual aversion, meaning that they do not want to have sexual intercourses. Sexual arousal disorders, in which the patient have no problem with their sex drive, but the patients have an erectile dysfunction, meaning that there might be something wrong with them, for which the patient can get erectile dysfunction. First and foremost, in order for erectile proper functioning, is this a sympathetic or a parasympathetic response? Parasympathetic response. Okay. Parasympathetic response. Very good. Okay. So if people are always paranoid, are they sympathetic or parasympathetic? Anxious, paranoid. They're always sympathetic. Okay. So if you are not in a parasympathetic state of mind, can you have erectile proper erectile function? Yes or no? No. Okay. So one of the number one causes of erectile dysfunction is nothing's wrong with the patient. The patient is just anxious, paranoid. Okay, so that is the number one cause. Next one is orgasmic disorders. What are orgasmic disorders? In which there is anorgasmia, meaning that there is absence of orgasm. Okay, then Premature ejaculation. Okay, that's also a problem. Then we have sexual pain disorders, whereas dyspareunia. Okay, dyspareunia is painful sexual intercourse, and vaginismus. Vaginismus is another type of issue in which there is also pain during sexual intercourse. Okay, it's not. These are not high yield. These are not very high yield. You will not receive a lot of questions from here. So there's no need to discuss them any further, except the fact that erectile dysfunction. Okay, try to understand that erectile dysfunction over here you have sympathetic, parasympathetic. Parasympathetic is responsible for proper erectile function. Okay. Okay. So, what are the differential diagnoses? The differential diagnosis is the number one cause, as we have said before, is psychological. Psychological meaning the patient is anxious. So, patients are not in a parasympathetic state of mind. So, they have erectile dysfunction. Next one is diabetes and low testosterone. These are endocrinological problems. Okay. Neurological problems, you have spinal cord injury in which there is not proper nerve innervation. Okay. Then insufficient blood flow, for example, atherosclerosis would happen because we know blood flow through the corpus, to the corpus spongiosum of the penis is important for proper erectile function. So proper blood flow. Another one is substance abuse. If we have a person who is on substances, for example, antidepressants, alcohol, drugs, they will have erectile dysfunction. That's that. Okay, you will not receive a lot of questions from here, so that's that. But out of this page, the important things are anorexia and bulimia. Do not forget about the BMI. Do not forget about the BMI. That BMI is low for anorexia and normal for bulimia. Okay. Okay. Next one is sleep terror disorder. Okay. So what is sleep terror disorder? These are periods of uncontrollable terror. Okay. First of all, before we move to sleep terror, at which stage of the night does sleep terror occur? Sleep terror. Which stage of the night? Very good. Okay, very good. Is sleep terror, and at which state of the night does nightmare occur? Nightmares, REM sleep. Very good. Okay, so sleep terror is basically screaming at the middle of the night. Okay, screaming because you're terrorized the middle of the night. Okay, when you have a night terror, do you scream? Yes or no? Do you scream when you have a night terror? No, you do not scream when you have a night terror. If you're screaming when you have, I'm sorry. Do you scream when you have a nightmare? Is what I meant. Do you scream when you have a nightmare? Yes, you do not scream when you have a nightmare, but when you have a night terror, you scream. So you're right. Okay, my apologies for asking the wrong question. Okay, that's that. Okay, so that's all that you have to know. Sleep terror, which stage? Nightmares at which stage? That's all you have to know from over here. Okay, next one. Next one is, okay, aneurysm. Next one is aneurysm. This is nighttime urinary incontinence 2 or more times per week for more than 3 months in anyone above 5 years old. Okay, this is something which you have to review and recall. The night sleep aneurysm is basically bed wetting, meaning adult patients who wet their beds for 2 times a week for 3 or more months in patients who are more than 5 years old. So it could be an adult or an adolescent. Okay, but the first line treatment is behavioral modification. Okay, fluid restriction, meaning that you tell the patient to not drink a lot of fluid. Okay, and positive reinforcement. Positive reinforcement is, once again, if it's a young child, then you want to make the child learn a new behavior by reinforcing that behavior with rewards. Okay, so that's what it is, a positive reinforcement. For refractory cases, we can also use some medications, right? ADH analogs. ADH, they will cause increased reabsorption of water. So this will put less pressure on the bladder. Okay, that's that. Are we clear about aneurysms? It's not difficult to understand, right? Okay. Most of the patients with sleep aneurysms, what they will tell you is they have a dream where they look, where in that dream, what they saw was they saw themselves urinating in the bathroom. In that dream, they were urinating in the bathroom. And that dream turned into reality. And in real life, they were actually wetting their beds. That is sleep aneurysms. Are we clear? Have you guys heard this before? Have you guys heard sleep this before? Yes. Okay. So that is sleep aneurysms. Okay. Next one. Next one is narcolepsy. Narcolepsy. What is narcolepsy? Narcolepsy is excessive daytime sleepiness with recurrent episodes of rapid onset of sleepiness more than 3 times per week for 3 months. Okay. Why is narcolepsy dangerous? Does anyone have any idea why narcolepsy could be dangerous? Anyone? Okay. What if a professional chauffeur or a professional driver has narcolepsy and during driving they fall asleep? Okay. Okay, this is extremely dangerous. Okay, so the problem with people with narcolepsy is they cannot control this feeling. That is overwhelming sleepiness. Overwhelming. The word overwhelming has been used, meaning that patients cannot control their sleepiness, and that occurs 3 times per week for the last 3 months. Okay, one of the proteins that is decreased over here is orexin or hypocretin, and this is produced in the lateral hypothalamus, and this is responsible for responsible for regulating the sleep wake cycles. Okay, so for narcolepsy, the only thing that you have to remember is diagnostically you will have decreased orexin. And can anyone tell me, where do we test for orexin? Do we test it in the blood or anywhere else? Where do we test for orexin? Very good. Okay, we test for orexin and the CSF. We do not test for serum orexin. There's no such thing called serum or blood test for orexin. We have to do a CSF study. Okay, so this is a protein which we can find in CSF. Okay. Now, the patients can get some hallucinations. Okay. So, what are the hallucinations? Do you remember that we talked about hypnagogic and hypnopompic hallucination? Hypnagogic are the hallucinations that they have just before going to sleep, meaning the patients will tell you that just before they close their eyes in narcolepsy, they saw a very vivid image of them in the garden or something, a nice calming image of them in the garden or something else. Okay, which allowed them to go to sleep, and that is hypnagogic. And hypnopompic is right after they wake up from that sleep. Right after they wake up from that sleep, they have a hallucination, which can be stress induced. That, let's say that there's something wrong going on, and then they're very active all of a sudden. This is known as hypnopompic. So all you have to know about hypnagogic and hypnopompic hallucinations are: hypnagogic are the hallucinations that occur before going to bed, and hypnopompic hallucinations are occurring after you wake up from your sleep. If you have a patient who has hypnagogic or hypnopompic hallucination, these patients are at increased risk of narcolepsy, or they already have narcolepsy. Okay, are we clear about hypnagogic and hypnopompic hallucinations? Okay. Next one is nocturnal and narcoleptic sleep episodes. Okay. What are these things? These things are called sleep paralysis. Do we have any student over here who has experienced sleep paralysis? Sleep paralysis. Okay. So you guys know exactly what we're talking about. And to all the students who has not experienced sleep paralysis, I'm sure you guys know what sleep. Okay, every one of you has had sleep paralysis. Everyone. Wow. Okay, well, no. Okay, so we have one. Okay, I have never experienced it myself, so that's what it is. But I know a lot of people. I know a lot of people who has experienced sleep paralysis. So that's basically what it is. That occurs. That starts with a REM sleep. Okay, that starts with a rapid eye sleep, and then all of a sudden you feel that your entire body is trapped and you cannot move your body at all, and you are and you are into a very deep sleep. That is sleep paralysis. Do you have to get a lot of questions from sleep paralysis? No. The answer is no. Do you have to get a lot of questions from cataplexy? Do you have to get a lot of questions from cataplexy? Yes. There we go. Good, very good. This shows that you guys are doing the questions properly. Okay, cataplexy. So we have to understand what cataplexy is. So patients in narcolepsy, before they fall into that overwhelming sleep, right before they fall into that overwhelming sleep, in they have a change in their personality. Like out of nowhere, they will start laughing. Okay, they will start acting a bit abnormal. Either that's one type of cataplexy. Another one is all of a sudden they will lose all their muscular tone. They will lose all their muscular tone because of a strong emotional stimulus. Next time you receive a question on cataplexy, they will not tell you what cataplexy is. They will tell you that you have a patient right before falling asleep. The patient felt like the patient could not move their hands and bodies. I mean, their hands and feet, their hands and legs. If you receive any type of question, right, that where they tell you that the patient has some sort of a paralysis, um, temporary paralysis before going to bed, try to realize that they are talking about cataplexy. Okay, try to realize they are talking about cataplexy. Okay, so are we clear on cataplexy? Okay. If you have a patient with cataplexy, if you have a patient with cataplexy, what is cataplexy? Cataplexy is basically, once again, for Dr. Mohammed Abu Riyad. Okay, for patients with cataplexy, before going to bed or before falling into that overwhelming sleep or narcolepsy, out of nowhere, some patients will lose complete uh, motor sensations of muscular tones in their hands and feet, and they will be more or less paralyzed temporarily. Okay, this is called cataplexy. This occurs right before going to narcolepsy in not all patients, but some patients. Okay, either that or some patients can fall into an episode of laughing. Okay, and when they keep on laughing, and then all of a sudden they fall asleep. This is called cataplexy. Okay, since we are talking on cataplexy, before moving on to Dr. Adhanam's question on sleep paralysis, I want to talk to you about the fact that you have a question in UWorld about cataplexy. How do you treat narcolepsy with cataplexy? What is the one single drug you will give to your patient who has cataplexy along with narcolepsy? Nope. I want the name of the drug, please. No, not modafinil. It's sodium oxybate. Okay, sodium oxybate. You don't have to write it down. It's in your first aid already. Okay, sodium oxybate. Write it down. Okay, write it down beside here. Where is sodium oxybate? Okay, sodium oxybate. Sodium oxybate. Okay, write it down over here. Sodium oxybate is used for cataplexy, especially with cataplexy for narcolepsy, and this is tested in real world. I promise you will come across this question. I promise. Okay. Okay. Now, sleep paralysis. What is sleep paralysis? Okay. Can I hear an experience of sleep paralysis from one of the physicians who has undergone sleep paralysis so that I can evaluate the paralysis? Does anyone want to talk about their experience of sleep paralysis very quick so that Dr. Adhanom and I can understand? Anyone who wants to talk about the sleep paralysis? How does a sleep paralysis feel? Okay. Are you awake or are you not awake? Okay. So you are not really awake. Okay. You are semi awake. Okay. You are semi conscious. You're not fully conscious, but you're semi conscious. Okay. That is sleep paralysis. Okay. Have you understand, Dr. Adhanom, after hearing the comments from all the other students? Okay. Okay, good. Okay. Next one. Next one is a very big problem over here. I'm not sure how big of a problem this is in your countries, in your respected countries, but in all countries we have this issue. What is this issue that I'm talking about? This is a substance use disorder. Okay, drug abuse. Substance use disorder. Do we have any students over here who can confidently say that my country is devoid of problems of drug abuse? No. Is do I do we have any students over here? Okay, that is very scary because our lectures have students from countries of all over the world. If we have no student who can confidently say that drug problem is not big in my country, then drug problem is a very big problem. Okay. Having said that, you will meaning that as a physician you will get a lot of patients, okay, with these type of issues. Okay, so that's that. So what we will be talking right now is drug abuse and addictions. Okay, drug abuse and drug addictions. That's what we will be talking about. First of all, okay, first of all, let's see. Okay, okay. The number one drug problem over here in New York as of right now and in Canada is a very expensive drug. And since everyone over here in New York has the ability to have a decent job, the drug is being more and more available. And the number one drug over here is cocaine. Okay, cocaine abuse, number one drug for New York, Canada. Okay, I'm pretty sure you guys have your own drugs in your own countries. I'm not sure how available cocaine is in your countries. Okay, uh, the country from where I initially am from is Bangladesh. Over there, the number one drug problem was opioids and methamphetamines, or okay, opioids and methamphetamines. Okay, do we have any other? Do we have any other country with any other drug problem that I would be a bit aware of? I would be a bit aware of any other countries with any other drug problem. Alcohol is not a drug. Okay, alcohol does not fall in this category. Substance use, okay. You can also say, you can also say alcohol for substance use disorder to some extent, but okay, that's that. So different countries have different types of substances which people abuse. Okay, so the thing is, okay, so how do you understand that a person has a substance use or a drug abuse problem? Okay, the criteria for diagnosing a patient with drug abuse or substance abuse is the person will have a maladaptive pattern. The person will have a maladaptive pattern of drugs, of that one single drug. For example, let's say cocaine, maladaptive pattern of using that drug for 2 times or more in 1 year. What do I mean by maladaptive pattern? A lot of people try drugs to see how they feel, okay, to experiment with drugs, and then they stop doing it. Okay, that's not a drug abuse problem. If people have a maladaptive pattern of abusing the drugs, for example, they keep on doing the drugs uh, over and over again. For example, in one episode, they do a straight 3 days of drugs, okay, and then they have another episode like this again, in which they do that same drug again for straight 3 days in 1 year, and they do it more than 2 times or 2 times, then that person can get diagnosed as a substance abuse or a drug addict. Okay, that person can get diagnosed as a substance abuse disorder or a drug addict. Okay, so that's how you can diagnose a patient if he or she is a drug addict or not. Okay, next one is what are the maladaptive patterns? First one is that said was binging. Okay, binging is basically you binge for 1 to 3 days straight, and then you stop, and that's one episode, and then you go for another binging, that is another 1 to 3 days, and then you stop, and that's another episode. That's one type of maladaptive pattern. Another type of maladaptive pattern, number one, is tolerance. What is tolerance? Tolerance is that single amount of drug which used to get you high. Right now, that amount is not enough. You need to have more. Okay, so that is tolerance. Next one is withdrawal. What is withdrawal? Withdrawal is when you don't have the drugs with you, or when you're not using the drugs, you have changes in your personality and your behavior and your physiology. Okay, that is withdrawal. Next one is always using more. Okay, using more. You need more drugs, more drugs. Okay, more is better. Less is okay. You never want to stop. Next one is persistent desire. Next one is you have a persistent, the drug addicts, they have a persistent desire to abuse that drug. Okay. Next one is impaired functioning. Impaired function. They cannot function properly. They cannot work properly. Okay. Next one is social conflicts. They do not have friends and families. who love them or who have gave up on them. Okay, so social conflicts. That's what it is. Okay. Next one is they have reduced their recreational activities, meaning that they used to once go out, have fun with their friends. Now they all they do is they think about that drug. Okay, so that's decreased recreational activity. So these are the things that are identified as a maladaptive pattern of drug abuse. You do not have to remember all of these things. Okay, these are all the things which I have said, so that when you guys come across questions, you guys can identify people with these problems and you can classify them as a substance abuser or drug addict. Okay, now if you have a drug addict and right now he has to overcome the addiction. Okay, right now he has to overcome the addiction. There are certain stages through which he has to go through or she has to go through in order to overcome that problem. Okay, can you guys hear my voice? Okay, tolerance. What do you mean by tolerance? Tolerance basically means that you are, let's say you have a certain amount of the drug and that used to get you high. Okay, the next time when you use that certain amount of drug, right now it does not cause you it does not get you high anymore. You need more drugs to get you high, so you're tolerated from the first dose. That first dose, your body tolerates it. Okay, that's what tolerance is. Okay, that's that. Okay, next one is what I want to talk about is if a drug addict wants to overcome the addiction. Okay, if a drug addict wants to overcome the addiction, there are certain things that he has to. Okay, can you guys hear my voice? Can you guys hear my voice? Okay. Okay, so there are certain stages which the drug addict has to go through in order to overcome the addiction. Okay, so the first stage is when you tell a drug addict that he has a problem. Do you think that he will tell you that yes, you're right, I have a problem? Yes or no? No, he will not say that he has a problem. Okay, to him it's normal. So the first stage is denial, denying the problem. This is called pre-contemplation. Okay, this is very important, guys, because you have a lot of questions in your world from the stages of overcoming drug addiction. So please pay your attention. First thing is when you tell a drug addict he has a drug problem, he will tell you that he has no drug problem. So the first stage is pre-contemplation. Okay, pre-contemplation. The word pre-contemplation. This means denial or denying the problem. Okay, you deny the problem. Next one, when you explain to the drug addict once again that look what's happening around you, look what you are doing, look how this is affecting your family member, and look what happened the last time when you did this, when you did that. And if everything goes right, if he understands the problem, is there a possibility if you talk to him very nicely and if you break down everything, maybe he will not change, but he will acknowledge that he has a problem? Yes or no? Okay. If you try to make him understand in a calm state of mind and he is also sober, then he will understand that he has a problem, but he won't change. He won't change, but he will understand. Over here, he did not even understand that he had a drug problem. Okay. You called him a drug addict and he got angry and he said, I'm not a drug addict. Right now, he is admitting he's a drug addict. Okay. So this stage is called contemplation. Okay. This stage is called contemplation. Okay. Next one. Next one is over here in contemplation, they did not want to change their action. Right now, if they want to contemplate at any point, if they think that they have the problem, okay, do you think that at one point, if it's a drug addict who wants to recover, if he thinks, finally decides that he has the drug problem, do you think there's a possibility that he will prepare to change? Yes or no? Is there a possibility that he will prepare to change? Yes. It will be difficult, but he will prepare to change. If he wants to really change himself, then he will prepare to change. So the next step is after contemplating, that is after you realize that after the drug addict realize that they have a problem, the next one is preparation. Preparation meaning he is preparing to make a change in his life. preparation. So he is preparing. Okay. Fourth one, after preparing. Okay. After he prepares to what, let's say nowadays this drug addict, instead of going to parties and to drug dealers and the hangouts where drugs are involved, he will start going to the gym. Okay, he will start going to the gym and involve himself with good people. So that's what he wants to do. And if that's what he wants to do and he does it, the next step is action. So he is putting action into his preparation. He thought about doing something and now he is doing something. Right now, if he keeps on doing, if he keeps on doing this for a long period of time, the next step is he has to maintain it. So the next step is maintenance of action. Okay, the next step is maintenance. And if he maintains this, let's say he has stopped having drugs. Right now he goes to the gym, he has a good set of friends, he goes to the office. Okay, and he is maintaining this lifestyle and behavior. Is he now a drug addict? Yes or no? Is he now a drug addict? Okay. So right now, if that drug addict is in the stage of maintenance phase of the addiction, so he is no more a drug addict. Okay. Okay. Now what happens is there is another scary stage, and this is a very bad stage. Okay. What happens is, if everything is going well, then this is exactly how an overcoming drug addict's life will look like. Pre-contemplation, where he denies the problem; contemplation, where he accepts he has a problem; preparation, he prepares to change himself; action, that is he puts into work about what he thought he can do to overcome his problem. So he is doing the action. And fifth is maintenance, he maintains the action. Sixth one sixth one is, for some reason, if something goes wrong, this person can fall into this bad stage, that is relapse. Okay, relapse. What is relapse? Relapse is basically returning to old behaviors and then again being a drug abuser. This is this is quite uncommon. If a drug addict is already in this stage, okay, and he is happy with his life, high possibility he will not go to this relapse stage even if he wants to. Okay, I mean, even if you, I mean, if he really wants to, he might. But most of the drug addicts know by now that they have they cannot go back because they have already put in so much work over here. These are years of actions. Okay, so that's that. So they will never go into relapse. But the sixth stage is relapse. Okay. So if I tell you right now, okay, if I tell you right now that you have a drug addict who is actively thinking of changing his life. Okay, he is thinking of changing his life. He is thinking of going to the gym. At which stage is he in? Preparation. Very good. It's not contemplation. In contemplations, it's not contemplation, because in contemplation they know they have the problem, but they are not prepared to make a change. If they are prepared to make a change, then it's preparation. Okay. If I tell you that, you tell a drug addict that he has a drug problem and he completely denies it, at which stage do you think he's in? Pre-contemplation. Okay. If I tell you that you have a drug addict, okay, who is trying to do the best and stay away from drugs, and now he is sober for 10 years, he is complaining. Okay, maintenance. That is the maintenance phase. Okay. Have you understood this? Have you understood these stages? Okay. Okay, good. Okay, so with that being said, we are finally more or less over with the psychiatric illnesses. Okay. Now we will start with psychiatric emergency. Now we will start with psychiatric emergency. Okay, what are the psychiatric emergencies? Okay. Before we move on to psychiatric emergency, which is a big topic, do you guys want to take another 5 minute break? Okay, so let's take that 5 minute break, and after that, we can come back and finish psychiatric emergencies and drug intoxications. Mhm. Okay. Okay, are we all back from our break? Are we all back from our break? Okay. Okay, so so far, since we are just done finishing all the psychiatric illness and psychiatric problems, are we all clear on the psychiatric problems? Okay, so what is the next thing you have to do in order to incorporate this knowledge and maximize your application to this knowledge? What is the next step? Very good, Dr. Karbasi, Dr. Uday. Okay, absolutely, absolutely correct answer. Okay, the correct answer is do questions. If what would happen if we do not do questions right now after learning psychiatry? What would happen? Fast answers, please. What will happen if we do not do questions? Forget everything. Absolutely beautiful. Okay. Bye bye. Knowledge, goodbye. Okay. You can say bye bye, bye bye, knowledge. Okay. And then everything, you will forget everything. Okay. So, very important that you apply this knowledge now and then and then. Okay. Having said that, let's begin. Okay, let's begin with the second part of psychiatry. Okay, we are done with psychology, we are done with psychiatric illness. Okay, and now let's begin with the second one. Okay, second one is, I mean, the third one. Third one is psychiatric emergencies. What are psychiatric emergencies? Okay, first and foremost, we will talk about a syndrome which is very well known to us. Okay, serotonin syndrome. First of all, we will talk about serotonin syndrome. Okay, and what is serotonin syndrome? That is any drug that can increase the 5-HT. Okay, can I? Okay, I really want to finish this at one go. Okay, I really want to finish the psychiatric emergencies at one go. So what I would need you guys to do is while I read through first aid with you, you can have the liberty to unmute yourself and ask me questions if you want. Okay, but ask me questions when I ask you to ask me questions because I do not want to have my thought track disturbed. Okay, so I will ask you whether you have any questions or not, and if you have any questions, please unmute and ask the question so that I don't have to come to the chat box and see again and again. At the same time, if I ask you to answer something, if I ask you to answer something, please do it too. Okay, please answer me that. Okay, so
You didn't share the screen.
yeah, I will share the screen right now. I will share the screen right now. Okay, so let's begin. Okay, let's start. Okay, so the first thing that I will start is serotonin syndrome. So, what is serotonin syndrome? That is basically any drug that can increase the 5-hydroxytryptamine. Okay, these are psychiatric drugs. Okay, for example, monoamine oxidase inhibitors. We all know these drugs. SSRIs, meaning selective serotonin reuptake inhibitors, SNRIs, select serotonin norepinephrine reuptake inhibitors, TCA tricyclic antidepressants, vilazodone, vortioxetine, buspirone. These are the psychiatric drugs. Okay. In non-psychiatric drugs, what you have is tramadol, ondansetron, triptans, linezolid, MDMA, dextromethorphan, meperidine, St. John's worts. Okay. Now, the unfortunate news is we have to keep in mind about all the drugs. We have to review or memorize all these drugs. And how do we do this? How do we understand or how do we memorize these drugs? Okay. First of all, for the psychiatric drugs, it's not hard for us to understand that monoamines, SSRI, SNRIs, TCAs, these are these are the four drugs which are very easy to understand that they will cause psychiatric drugs. In order for you to remember vilazodone, vortioxetine, and buspirone, we will use a short diagram. The short diagram that we will use is there is a villa. Okay, there's a villa. By villa, we know what a villa means. It could be like a building, or that's what it is. Okay, how do you go to a go? How do you go to the villa? You go to the villa with a bus. Okay, you are going to the villa with a bus. Okay, and while you're going to the villa in the bus, you have a storm. Okay, how is the storm appearing in front of you? The storm is appearing to you in form of a vortex. Okay, the storm is appearing in front of you in form of a vortex. So you have the villa for vilazodone, bus for buspirone, and the storm which is appearing in front of you like a vortex. Vortex for vortioxetine. vortioxetine. Okay, so remember the three drugs by this one small story. Okay, or else you will guys will forget this. The reason why I'm telling these stories is because I want you guys to recall and memorize these drugs right away. And the easiest way to do this is to associate stories with the drugs. Okay, and you will not forget this. Next one. Next one is non-psychiatric drugs. Okay, non-psychiatric drugs. First of all, is we have you guys heard of trams? Trams? Yes or no? Trams. Have you guys heard of trams? You
Yes.
can, yes, you know what a tram is, right? Like a tram is a
Yeah.
tram track when they go on trams. Okay, so first of all, we have a tram. On that tram, okay, on that tram is on a straight line. Okay, that tram is on a straight line. If a person tries to cross the tram, okay, if a person tries to cross the tram, he might not he might not see the tram tracks, and then he can trip on it. Okay, so he can trip on the tram tracks. Okay, so a person tripping on the tram tracks. After that, why is this person tripping on the tram tracks? This person is tripping on the tram tracks because this person is not himself. Why is he not himself? Because he is on high dextromethorphan, and also he had St. John's worts. Okay, St. John's worts are basically these are basically over-the-counter drugs that we can find over here that helps you with elevating your mood. Okay, these are over-the-counter drugs. So this guy over here, he had dextromethorphan, St. John's warts. Okay, and another thing is, after this guy fell, okay, after this guy fell, he started to have extreme vomiting. Okay, and the drugs that was prescribed to him for his vomiting was ondansetron. Okay, the drugs that was prescribed to him for vomiting was ondansetron. Okay, and another reason which we found out later when he was taken to the hospital is that this guy, he tripped on the tram tracks which were on a straight line. Is not only was he on dextromethorphan, St. John's worts, and he was given ondansetron, he was also on another drug, that is MDMA. MDMA is ecstasy, so he was on MDMA. Okay, so that's what it was, and that's that. Okay, I skipped out on meperidine because it's not that high yield, so that's that. So in order for you to remember all the non-psychiatric drugs, first of all, tram tracks for tramadol, straight line, linezolid. Remember this small story. Then a guy who trips on the tram tracks trips for triptans. Why did he trip? He tripped because he was on MDMA, St. John's wort. Okay, and after he tripped, he had vomiting. For his vomiting, what did we give him? We gave him ondansetron. And then for this, he was taken to the hospital. And in the hospital, when we did a blood study, we found that this guy also took ecstasy or MDMA. So if you study like this, you can easily understand all the psychiatric drugs that can cause serotonin syndrome. Now, who is who has the courage to tell me the names of all the drugs? Anyone? Anyone? All the drugs that can cause serotonin syndrome. Who has the courage to tell me the names of all the drugs? And I believe everyone should have this courage to tell me the names, because all you have to do is just like remember the story. And I will appreciate anyone who tries, because I know you guys cannot name all the drugs right away, but you guys can try. Okay. So anyone? Can you guys hear my voice? Can you guys hear my voice?
Yes, yes, doctor.
Okay, so why can't please, I would appreciate if anyone tries from my story over here. Okay. Okay.
Okay, I will try, doctor.
Okay, so we have Dr. Hussam. Let's go. So first and foremost, serotonin syndrome. What is the thing that is increased over here?
5
5-hydroxy.
5-hydroxytryptophan. Yeah.
Very good. What are the two types of drugs that can cause serotonin syndrome? We have psychiatric and non-psychiatric, right?
Yes.
Okay. Can you name the psychiatric drugs?
Yes. SSRI, SNRI.
SNRI. Fast answers, please. Monoamine oxidase.
Yeah, monoamine oxidase inhibitors. Valizodone and
Vilazodone and
Vortio.
What did we use to go to the villa? What?
Yeah, Vortex. So
There was
Vortiox.
Vortioxetine and which
Vortioxetine and buspirone.
Buspiron. Very good. Okay.
Aspirin.
Very good. So we used the bus to go to the villa, and there was a storm of vortex in between. So vortioxetine, buspiron, and vilazuron. Very good. And what are the non-psychiatric drugs that we just talked about?
Yeah, so tram for
Tram
tramadol,
for tramadol, then
trip for triptan,
triptans.
um, yeah, for triptans, a line for linezolid,
Very good.
um, then the two personalities, dextromethopran and G and
Dextromethorphan.
some,
St. John's warts. Very good.
yes, St. John's.
And then did he have vomiting?
And yeah, he vomited, so we gave him odansetron, and he
Ondansetron.
was we detected in his blood drug, so we gave him Namda.
MDMA. Very good. So the drugs. So thank you, Dr. Bassam, for telling us more or less everything on all the names of the drugs
You are welcome.
for serotonin syndrome. Okay. Has everyone understood the mnemonic, the story mnemonic for the drugs? If you say yes, we have to move forward. Okay. Has this been useful, or did this confuse you guys more? Useful or not useful? More confusing, less confusing. Okay. Okay. So did even if you guys did not participate, did you guys at least draw down the story so that you guys don't forget this? Okay. Okay. Easiest way to memorize things. Okay. If easiest way to memorize things. Dextromethorphan. Do you remember that guy when he tripped? Why did he trip? He tripped because he was on dextromethorphan and St. John's wort. So he did not see the tram track, so he tripped. Okay. Dextromethorphan. Okay, so once again, the easiest way to easiest way to memorize things is not blatantly memorize. If you cannot understand the mechanism, try to associate a story with the whole thing, and you guys can memorize everything. Okay, next one. Next one is manifestation. So what is manifestations of serotonin syndrome? Number one is increase in activity. Okay, so what are the activities that will increase in serotonin syndrome? Obviously, increase in serotonin would result in neuromuscular clonus, okay, hyperreflexia, hypertonia, tremor, seizure, okay, everything will increase. Autonomic instability, meaning patients will be hyperthermic, okay, diaphoresis, and also the mental status will be altered. So altered mental status, okay, these patients will have altered mental status. Okay. Now, how do you treat a patient with serotonin syndrome? You treat a patient with serotonin syndrome by using a serotonin receptor antagonist. Serotonin receptor antagonist. Okay. The name of the serotonin receptor antagonist is cyproheptadine. Do I have to use any story for cyproheptadine? Because I'm pretty sure a lot of you guys know cyproheptadine. Yes or no? Can I hear the answers, please? I do not want to go chat box. Do I have to associate a story with cyproheptadine?
No.
Okay.
No. Yes.
Okay, yes. Okay, so we have one yes. So let me associate a story with cyproheptadine. Okay, I was really not planning to associate a story with it. Okay, since I was not planning to associate a story with it, I have to come up with something. Okay, so, okay. What happens when this patient, okay, right now, okay. So who was the doctor who said yes, that she needed a story for cyproheptadine? Who was the doctor who said yes for the story of cyproheptadine? Don't worry, I will not scold you. I just want to help you. Was it a ghost who said yes? Who was the doctor who said yes? Okay, Dr. Maheshwari. Okay, good. Okay, so if you have this young guy over here who tripped on the tram tracks in front of everyone, okay, and then after he went to the hospital, okay, right now, what if I tell you that this guy is sitting in front of the tram track, okay, he is now sitting in front of the tram track. His serotonin syndrome is not happening anymore. This whole thing that happened, he's not that is not happening anymore. So this guy, he's sitting in front of the tram track over here quietly doing nothing. This time, instead of having dextromethorphan and St. John's worts, he is sipping on coffee. Okay, sipping. So he is just sipping on a cup of coffee, and he is looking at what he did last week. Okay, last week he tripped on the tram tracks. So sipping on coffee for sipping for cyproheptadine. Okay, does that help? Okay, perfect. Okay, good. Very good. I'm glad I could help you out. Okay, good. Okay, next one. Next one is, let's go to the next one. That is hypertensive crisis. What is hypertensive crisis? First of all, let's talk about hypertensive crisis. That is tyramine containing food. Okay, tyramine containing food. Why is tyramine rich foods important for um, causing hypertensive crisis, especially when the patients are on MAOIs? Who knows? What
Was
is
it
the
metabolized by mouth?
Metabolized by
Because
someone
it's get
to
metabolized by
what?
this enzyme.
To what?
It will inhibit the breakdown of monoamine oxidase.
Okay, no problem. But tyramine, okay, tyramine is broken down to which product? Anyone? Anyone? Tyramine? How does tyramine cause hypertensive crisis? What are the neurotransmitters that comes from tyramines?
Maybe norepinephrine?
benefit.
Dopamine, norepinephrine, epinephrine, right? Am I correct?
Yes.
Yeah.
Yes. Okay. So if
Yes.
okay, so if I do not okay, so while taking monoamine oxidase inhibitors, if I take monoamine oxidase inhibitors, will there be more monoamine or less monoamine?
Less.
Mono.
Less.
Okay. So as a
No,
matter of
It will
it more because it inhibitors.
exactly, so there will be
Yeah.
more monoamine oxidase inhibitors. So if we have more breakdown of tyramine products, will there be more epinephrine, norepinephrine, and dopamine? Yes or no?
more.
More, yeah.
So because they are the metabolic products, am I correct?
Yes.
Yes.
Okay. So if you have increased amount of epinephrine, norepinephrine, and these things, are they important for causing hypertension? Yes or no?
Yes.
Yes.
So these
Increase
patients
sympathetic.
exactly. So these patients can get hypertensive crisis. Okay, so that's what it is. So what are the food products that contains tyramine? Tyramine food products are basically cheese, wine, chocolate, and cured meats. Cheese, wine, chocolate, and cured meats. Okay, by cured meats, we mean meats that are processed meats. Okay, so that's what it is. Hypertensive crisis is basically the tyramine will displace other neurotransmitters in the synaptic cleft, and this will increase the sympathetic stimulation. That's exactly what we have just discussed about. Okay, what do you give for treatment of hypertensive crisis? Phentolamine. Okay, what is phentolamine?
It's alpha
Alpha to blocker.
blocker.
Alpha non-selective, I think, blocker.
Alpha.
Okay, what happens?
Non-selective alpha blocker.
Okay, what happens when you block the alpha?
It will vasodilate.
Okay, good. So as a result, what will
Yeah.
happen to the hypertension?
Decrease.
Will decrease.
The phentolamine, is it an alpha 2 blocker or alpha 1-2 blocker as a whole?
1, 2. Yeah.
1, 2.
It's not a select blocker, okay? It is a
Yeah.
generalized blocker. Okay, so no more mnemonics for hypertensive crisis. Easy to understand. It's not a problem. Next one is our friend over here. Why are we calling this our friend? Because we have studied this so much in the past. Am I correct? Do you guys remember we talked about anesthesia and malignant hyperthermia and how we use dantrolene? Yes or no?
Yes.
Yes.
Okay, so that is malignant hyperthermia, the one for anesthesia. This one is different. This one is not malignant hyperthermia, but the process is more or less equal. The thing is, the only problem with neuroleptic malignant syndrome is instead of anesthesia causing those type of issues, so for example, succinylcholine, we have antipsychotics over here, which can cause neuroleptic malignant syndrome. Okay, and the signs symptoms are more or less the same. What's happening over here is you have a malignant fever. So patients have high fever. And then when you have fever, do you have shaking? Yes or no? Do you
Yes.
shake? You have high
Yeah.
fever? If you shake, is there a possibility that you will have small muscular breakdown?
Yes.
Yeah.
Okay, so as a result, patient can get myoglobinuria. Okay, if you have a patient with myoglobinuria for a high amount of time, will those patients, are those patients predisposed to having acute renal failure?
Yes.
Yeah.
Yeah.
Yes, so that can also happen. So fever, encephalopathy, unstable vitals, CK. When does CK increase? Fast answers, please.
When
does
muscles
Muscle.
muscle breakdown?
Muscle
damage.
breakdown. Yeah.
Right. True. And another one is muscle rigidity. Okay, the muscles will be rigid. Okay. What do we use for these type of problems? We use our regular drug over here, that is dantrolene. Okay. Do we use dantrolene in malignant hyperthermia?
Yes.
Yeah.
Okay.
Yes.
And another fact is we can also use dopamine agonist. Okay. But the fact is dopamine agonists are less potent than dantrolene. And for the purpose of solving UWorld questions, you will not get dopamine agonists over there as an answer option. You will always get dantrolene. So keep that in mind. And do not forget to have the proper knowledge to differentiate malignant hyperthermia and neuroleptic malignant syndrome. Okay. Next one. Next one is delirium tremens. Okay. Delirium tremens. Have you guys heard about delirium tremens before? Didn't you guys ever?
Yes.
Okay.
Yes.
Okay.
Yes,
So
yes.
what is delirium
Alcohol.
tremens? This is basically alcohol withdrawal. If an alcoholic, okay, if an alcoholic he goes out of drinking alcohol for 2 to 4 days, 2 to 4 days, they go into a state which is called delirium tremens, which is characterized by altered mental status, aggression or agitation, insomnia, hallucinations, hyperactivity, anxiety, autonomic seizures. Okay, I personally have a story in my days of serving in the hospital when back home when I had to deal with delirium tremens. Okay, what happened was we had an alcoholic patient who was admitted to our cabins. Okay, and we did not know he was an alcoholic. So what happened was, since he was out of alcohol, he got diagnosed with pancreatitis, and that's a very common diagnosis with alcoholism. So he was not on any food, or he was not taking any food or water through his mouth. So that's what we do. We do a gastric rest in pancreatitis. Okay, so the patient was on a strict IV. So what happened was that two at night, the patient started acting extremely agitated. The patient had hyperactivity, anxiety, seizures, and tremors. And the reason why I shared this story with you is, even in UWorld, you will see that in most of the cases, in UWorld cases, these patients are inpatient problem. This is an inpatient problem. Alcoholic patients, when they get admitted to the hospital, then they have an increased tendency of having delirium tremens. Okay, when they have a delirium tremens, what is the best drug that you can give them? Fast answers, please.
Benzodiazepine.
Benzodiazepine. Okay, benzodiazepine. Out of all these drugs, the most important drug is lorazepam. Okay, IM lorazepam, chlordiazepoxide or diazepam. If you give an alcoholic patient, if the patient is drunk, if you give them, can you give them benzodiazepines?
No, there will be potentiation.
No.
Excellent. So, okay, so this answer is a bit contradictory. First of all, if you have a patient who is an alcoholic who is having agitations, you actually can give them lorazepam. IM, intramuscular, low dose lorazepam. You can give them lorazepam, but there are things which you have to do. What is the next
For
thing?
respiratory.
I'm sorry?
What respiratory depression?
Exactly. So you have to keep a very close eye on his respiratory rate, so to prevent respiratory depression. If the patient goes into respiratory depression, what is your next step of management?
Ventilation. Antidote.
Ventilation or
For
intubation?
antidote, yeah.
Mechanical ventilation or intubation. Okay. Okay. Next one is acute dystonia. Okay. Had we discussed about dystonia before?
Yes.
Okay.
Yes.
So what is dystonia?
Torticollis.
Basically, that's what
Muscle
it is.
contraction.
Painful muscular spasms, painful muscle spasms, sudden onset of muscle spasm, stiffness occurring after medication use. Okay. And the most threatening one is if a patient has laryngospasm, meaning that the vocal cords of the larynx, if they undergo spasm, and if the patients undergo laryngospasm, then these patients can have life-threatening life that can be life-threatening, because if there's a laryngospasm, then the patients cannot breathe, and those patients will require intubation. Okay. What is the most common cause of acute dystonia? The most common cause of acute dystonia is typical antipsychotics, anticonvulsants, okay, metoclopramide, okay. Antipsychotics is one of the most important cause of acute dystonia. Okay, is acute dystonia an extrapyramidal symptom?
Yes.
Okay. Benztropine or dihydramine are the ones which we can give to patients with acute dystonia. Okay. Okay. Um, what the way you can remember this is the patient with acute dystonia. Okay, so you have a patient who comes to the hospital. Okay, this patient who comes to the hospital. Okay, this patient is not any patient. This patient is a very rich patient. Okay, you have a rich patient with acute dystonia who comes to the hospital. Do you guys know the name of the car in which he comes to the hospital?
Mercedes-Benz.
Mercedes
Very good.
Benz,
Okay.
Benz, yeah.
Okay, so this guy, he comes to the hospital in a Mercedes-Benz. Mercedes-Benz for Ben Stropen. Okay, and this guy, what is his problem? His problem is he has acute dystonia, but he doesn't want to come into an ambulance because according to him, ambulance is dirty, and he's rich, so he can come in his Mercedes-Benz. So Ben Stropen. Next one is extremely important: lithium toxicity. Can you guys name the diseases in which we use lithium? It's a very easy question, and I will need fast answer.
Polar.
Bipolar.
Schizophrenia.
Okay. So what is lithium toxicity and what are the causes of lithium toxicity? For you, world, this is extremely important, extremely important. There are causes of lithium toxicity. First and foremost is increase dose. Okay, I'm just going to use this text over here. I just want to finish this fast. Increase in lithium dose. Okay, so increase intake or decreased elimination. How can you decrease the elimination of lithium? First of all, if you have acute kidney injury, meaning that your GFR is less, so lithium will obviously accumulate in your blood. Another one is if you have medications that can alter the metabolism of lithium, that is thiazides, NSAIDs, and ACE inhibitors. These are the three drugs that you have to understand. So thiazide, ACE inhibitors, and NSAID. So ANT. Okay, these are the three ANT drugs which can cause lithium toxicity. Also, lithium toxicity, lithium has a very narrow therapeutic index, or a therapeutic window. So that's what it is. Okay. What are the sign symptoms of lithium toxicity? Nausea, vomiting, slurred speech, hyperreflexia, ataxia, and the most important one is this one, nephrogenic diabetes insipidus. Okay, most important one is nephrogenic diabetes insipidus. How do you treat a patient with lithium toxicity? First of all, aggressive hydration. Hydrate aggressively. Okay, because you want to hydrate the patient, you want to dilute the blood. And then second one is you want to consider hemodialysis because there is no antidote for lithium. So hemodialysis or filtering the blood through the hemodialysis machine. That's what it is. Okay, and obviously discontinue the lithium is number one. Okay, have we understood lithium toxicity?
Yes.
Okay, do we have any questions? No. Okay. Next one is TCA toxicity. TCA is tricyclic antidepressant toxicity or TCA overdose. Okay. What are the sign symptoms of TCA toxicity? First and foremost, the number one sign symptoms of TCA toxicity is an ECG problem. And we know this. This is called long QT syndrome. Okay. If I have to ask you this, can you guys name all the other drugs which can cause long QT syndrome?
Antipsychotic, antibiotic,
What are the names of antibiotics?
antiemetics.
What are the names?
Antipsychotic like haloperidol, droperidol.
And then
Antibiotics like macrolides, aminoglycosides.
Okay,
Antiarrhythmic.
anti-arrhythmics such as
Antiemetics also. Antiarrhythmics class
Class
A,
3
1
and 1A.
and class 3.
okay, and then what else?
Biotic like macrolides.
Antiemetics, metoclopramide.
Okay,
Low potassium, low calcium.
low potassium, low calcium. Okay,
There is
very,
one more.
very good, very good. Each and every one of you, thank you so much for answering. Okay, thank you so much. Do we have any other question from long QT syndrome? Did I hear a question in between the answers or not? Okay, that was not a question. Okay, so thank you so much. So these are all the other drugs, and all of that you have the antidepressants. Antidepressants have TCA, like this one over here. So TCAs. What does TCA? Another things which TCA can do is TCA can cause cardiotoxicity. They can cause arrhythmia, coma, and convulsions. Okay. But the number one thing to look out for is increased QT. Okay, what would happen is if you want to treat a TCA toxicity, first of all, you have to support the treatment. You have to have supportive treatment. Okay, monitor ECG, make sure that the QT syndrome has disappeared. And the next thing that you can do is administer sodium bicarbonate. Okay, sodium bicarbonate and activated charcoal. Okay, why do we use activated charcoal?
It will bind to TCA.
Okay,
Decrease absorption.
Okay,
It will overwhelm the TCA.
okay. That is basically, that's what it is. Okay, so we are done with, what are we done with? Psychiatric emergencies. Now we have to go to psychoactive drug intoxication and withdrawal. And do we want to continue this today or tomorrow? Okay. Do we want to continue this today or tomorrow?
Tomorrow, please.
Tomorrow.
The last page is very hard to study.
Okay, so what we will have right now is I will mute you guys and I will have a vote. Okay, let's see how many tomorrows and how many todays. Okay. Okay, so everyone for tomorrow, right? Tomorrow we have 1, 2, 3, 4, 5. I don't know what T is. T would be today or it would be tomorrow. 6, 7. Everyone tomorrow. Tomorrow, please. Okay. So not even a single student wants to read another single page for today. Okay. Okay. So we have one student, Dr. Hassan, who wants to study today. Dr. Hassan, who wants to study today. Okay. Tomorrow. Okay. Okay. I'm also in favor of doing it today. So even if it's 5 of us, there's 14, 15 other people who is more than that. Okay. So how about we start tomorrow? Okay. Okay. How about we start tomorrow, and then tomorrow we can finish psychiatry as a whole. Okay. We will finish psychiatric pharmacology, and then we will finish psychiatric, all the other ones. Okay. So we will finish the whole thing. We will finish psychiatry at one go. Okay. And then after that, what we will start with is, what is the next chapter after psychiatry? Who knows? Okay. We know. It's Thanksgiving tomorrow. Oh, it's already Thursday. Happy Thanksgiving to you too, and happy Thanksgiving to everyone. Okay, but having a Thanksgiving will not be affecting our classes, to be really honest. Okay, it will be at a regular time. So that's that. Okay. Okay. Good. Okay, so whoever has to skip out on tomorrow's lecture, no problem. We always send out the lectures to you guys via email. But what I need you guys to do is we delete the lectures very fast because we need to create space on our Zoom. So make sure to download the lectures when you get the lectures. Okay, if you don't download it, you will lose out on it. Make sure that you download the lectures. Okay. Having said that, let's start with the UWorld notes for today, because it's been a while since we did our UWorld notes. Okay, let's start with the UWorld note. And please try to stay because UWorld notes are very important. Okay, we can complete the whole thing. We will complete psychiatry tomorrow. Okay. Okay. Give me 1 second. Give me 1 second. Okay.
Listen.